Aram, are you there? Can you hear me?
Yes, ma'am. I'm here. I can hear you.
But the video thing is still disabled. I cannot.
Technical team.
Farhan?
Yes, sir. Hello.
तो फरहान?
Yes, sir.
डॉक्टर अदिति अग्रवाल का ये वीडियो ऑन नहीं हो रहा है, एक बार चेक करना।
वीडियो किसी का भी ऑन नहीं हो रहा है। डॉक्टर पीयूष है।
बाकी सब हटा दो ना। आपको कोर्स है। Hello, sir. Please try now.
Can I try sharing my screen?
Yes, ma'am.
अपना बैकग्राउंड सही कर लिया आदिति, यहाँ तो बैकग्राउंड कितना सुंदर है।
क्या?
तुमने अपना बैकग्राउंड एटलीस्ट सही कर लिया, यहाँ तो बैकग्राउंड की पॉसिबिलिटी नहीं है।
Yes, ma'am. You can try sharing your screen.
Yeah, I'm trying.
तो अरहम को भी को होस्ट बना देना प्लीज।
Can you see my screen?
Yes, ma'am. Yes.
Okay. So the timer that you were talking about will come where I go to gallery view.
Yes, ma'am. We are starting that now.
Start the timer.
Yeah, for demo purpose. Yeah.
So the thing that says timer, अच्छा यहाँ पे timer visible है. And
Yes,
suppose I go to the speaker view. I don't want.
ये टाइमर मैम अंदर नहीं जाएगा पोर्टल पर, ये आपको नजर आएगा, है ना? स्पीकर पर नजर आता रहेगा।
टाइमर कॉर्नर में नजर आ रहा है, अगर मैंने मिनिमाइज भी किया उसको।
हाँ जी।
टाइमर नजर आ रहा है।
जी जी।
ठीक है, क्योंकि स्पीकर तो गैलरी व्यू नहीं रख सकता ना, he has to see his screen also.
Yes, yes.
Somebody else will have to take care of that. He'll have to ping you.
मतलब स्पीकर नहीं ध्यान रख सकता, चेयरपर्सन एंड अदर पीपल कैन कीप अ गैलरी व्यू।
कवर हो जाएगी ना स्पीकर की तो।
राइट।
गैलरी व्यू दिखेगा नहीं ना तुमको तो। तुमको भी गैलरी व्यू दिख रहा है?
हाँ, मैंने गैलरी व्यू में रखा हुआ है, टाइमर दिख रहा है, पर उसमें टेक्स्ट छूट जाता है ना।
हाँ, तुम्हारा टेक्स्ट कट रहा है ना। That's a problem.
Aram, you have cross checked with all the faculty जिन्हें join करना है? Aram?
Hello, yes, ma'am.
Have you cross checked with all the faculty for hall D?
Yes, ma'am. I have. I did.
कोई डिफॉल्ट्स हैं, कोई ड्रॉप
No,
आउट है?
नहीं, अभी तक कोई नहीं। एंड मैम अनिल डिक्रूज सर अभी 10 मिनट में ज्वाइन करेंगे। एक्चुअली ही इज इन कार एंड वो घर पहुंच ही रहे हैं अभी, तो ही विल ज्वाइन।
कोई नहीं, 6 o'clock तक सर का सेशन स्टार्ट करेंगे, तुम मुझे बता देना। 6
Okay.
o'clock हम स्टार्ट कर देंगे, उस समय मुझे एक मैसेज कर देना।
डन ओके।
चैट में, प्राइवेट चैट में कर सकते हो ना, चैट दिख रहा है।
लगा दे मैम वो स्क्रीन हम अपनी, और लीव इट लाइक दिस ओनली।
हाँ, डॉक्टर पीयूष, यू वांट टू शेयर? नहीं, टुडे यू आर नॉट प्रेजेंटिंग एनीथिंग।
नो, आई एम नॉट प्रेजेंटिंग एनीथिंग, टुमारो इट इज देयर।
ठीक है, लगा दीजिए सर।
आज तो बस एक पहला तुम्हारे वाला सेशन में पैनलिस्ट हूँ, उसके बाद इनवाइट करना है और कुछ नहीं है, उसके बाद फिर पैनलिस्ट बन जाना है। आजकल तो यही रोल करने हैं ना, दोनों तरफ बैटिंग करनी है।
Anybody from technical team can tell me how many registrations till now?
Ma'am, only Avnish knows about this.
Can you please check with
We'll
him?
cross check and let you know.
Plus, somebody will have to basically tell after every session how many delegates have joined, because that we need to declare as per Rao sir. Real time दिखेगा ना attendees में. So if you see the participants, उसमें attendees में real time दिखेगा कितने लोग हैं.
नहीं, यहाँ पे सिर्फ फैकल्टी दिखेगी आपको।
नहीं, there are panelists and then attendees.
नहीं तो उन्हें अटेंडीज उन्हें नहीं बनाया जाएगा ना, वो डिफरेंट प्लेटफॉर्म पे हैं। Am I correct, अरहम?
Attendee कौन बनेगा फिर? Faculty तो attendee नहीं बनेगी।
नहीं, अरहम, जो डेलीगेट्स होंगे वो हमें
डेलीगेट्स
अटेंडेंस दिखेंगे।
डेलीगेट्स जो है वो प्लेटफॉर्म पे रहेंगे, जो हमारा प्लेटफॉर्म है उस पे।
नहीं तो यहाँ पे हमें जहाँ पार्टिसिपेंट्स दिखते हैं, हम सब पैनलिस्ट हैं, जो फैकल्टी है, अटेंडीज दिखेंगे?
नहीं, यहाँ पे नहीं दिखेंगे।
अटेंडीज में कौन है ये जिसने अभी हैंड रेज किया है?
में डॉक्टर सगीर आए हैं।
अदिति मैम,
सगीर, ओके।
अदिति मैम, मैं पंकज कौशल बोल रहा था। हाँ जी, हाँ जी मैम, क्विज की हमारी बात हुई थी ना मैम कल?
क्विज की, राइट?
हाँ जी, तो वी हैव रिसीव्ड क्वेश्चंस फॉर क्विज, तो उसमें क्या फील्ड्स रखने हैं? तो हमें रखना था नेम, ईमेल आईडी और मोबाइल नंबर और व्हाटएवर यू टोल्ड मी ना कि मैं आपको भेजूंगी। हाँ जी,
नेम ऑफ द पर्सन,
ओके,
द स्पेशलिटी, डेजिग्नेशन,
ओके,
and year of post graduation.
ओके, नेम, स्पेशलिटी, डेजिग्नेशन एंड ईयर ऑफ
Post graduation.
ईयर ऑफ
Post
graduation.
graduation. हाँ.
ओके,
Year of completion of MD/MS लिख सकते हैं।
ठीक है मैम।
उसके अलावा फोन नंबर और ईमेल आईडी।
फोन नंबर, ईमेल आईडी, नेम, स्पेशलिटी, डेजिग्नेशन, ईयर ऑफ पोस्ट ग्रेजुएशन, फोन नंबर एंड ईमेल आईडी, राइट? ओके मैम।
तो इसका मतलब कोई
हेलो हेलो
गुड इवनिंग सर।
हाँ मुदित
सर गुड इवनिंग सर।
मैं अभी घर पहुंचा हूँ। सुनो मुदित,
सर
बहुत लोग पूछ रहे हैं कि डेलीगेट लिंक नहीं मिली। ऑल माय जूनियर्स एट द हॉस्पिटल वर आस्किंग मी. I think you all should circulate it a little more aggressively. I know you're not an organizer, but maybe the Paris team, I can see some Paris folks on. You all should, the crowd, इतनी मेहनत की आप लोगों ने. If there are more people, it will be so much better.
Hello, Dr. Mudit. This is Dr. Aditi.
Yeah, Dr. Aditi.
Hi, Aditi.
Hello, sir.
Aditi, थोड़ा सा circulate करो. लोग मुदित को सुने.
Sir, we did circulate, but then I don't know how it did not reach.
अच्छा ठीक है. मे बी माई बम्बई वाले थोड़े से स्लो हैं दिल्ली वाले से कंपैरिजन में. मे बी दैट्स व्हाई. आई होप वी आर नॉट ऑनलाइन. आर वी ऑनलाइन?
वी आर ऑनलाइन सर.
नहीं, हम अपने बीच में है ना, या डेलीगेट्स भी सुन रहे हैं?
दिस इज लाइव ऑन यूट्यूब.
डेलीगेट्स नहीं सुन रहे सर.
डेलीगेट नहीं सुन रहे, बट दिस इज, आई थिंक दिस इज रनिंग रिकॉर्डिंग लाइव ऑन यूट्यूब.
अच्छा तो ठीक है. देन वी डोंट वांट टू टॉक एनी. वी लेट अस गेट डाउन टू सीरियसनेस. ओके मुदित, क्विकली.
Yes, sir.
I put a few slides together which will
Yes,
be purely inspirational.
Oh, right, sir.
To stimulate people to do research, why it's important. And
Right,
then
sir.
maybe you can field some questions. I also thought we've got a great panel with Alok and Mithali and some great head and neck minds. If you want, they can also participate, because
Right,
let's say
sir.
Alok heads All India, and then Mithali is out with the Paris groups.
Right.
is in private. I've been in both. So we
Right,
can,
sir.
you are in a semi-private, semi-government atmosphere. I think we can have different viewpoints to make it meaningful.
Right, sir. Right, sir. That's what I was thinking, that because and we will have something from you for your experience, sir, regarding that RCT which you have done, because that's a landmark you have done. So what all problems you faced and what was your experience regarding it and how difficult it is. So that's your we have to have your viewpoint regarding this, sir.
Okay. So I will start with the general thing, less
Right,
of
sir.
RCT, but
Yeah.
I can come back to the RCT when required.
Right, sir. Right, sir. And we will talk more, mainly focus on the problems which we face as a clinician, how to go forward
बिल्कुल,
with. Yes, sir.
बिल्कुल, बिल्कुल.
Right, sir.
जब भी आप लोग
So how
तैयार हो हमको बता दो. Is there a link that I can send to some juniors who wanted to join?
Dr. Aditi?
Yes, sir. I will send you.
There is a link. Arham, can you please send it directly to sir so that sir can circulate?
हाँ तो मेरे WhatsApp पे भेज दो, मैं फिर forward कर देता हूँ.
So, Dr. Aditi, can we invite Dr. Alok, Dr. Mithali for the panel if you want to do it?
So we can invite them, yes, but Dr. Alok, I think, will not be able to attend. So he had to travel, which was unavoidable. So he has sent a pre-recorded presentation.
Okay. That's okay. But any other person, Dr. Rangarao itself, is there? Must be there, na?
So Dr. Rao is there, but he's in a different hall. So Dr. Piyush can be a part. Dr.
Right.
Mithali is there.
Right. So anybody from the government sector who is there? Okay.
I'll just check. I'll just check.
Yeah. Technology, yeah. Yes.
Clinical trials, team के problems हैं, consent related problems.
Technological.
So capsule one.
Deficit. High-end technology. Like PCT.
Dr. Mudit, we can.
Yeah, we can start.
Just a minute. Yeah, so shall we start?
Dr. Aditi, we had discussed we discussed with Dr. DeCruz. So what we will do is that we can have his short presentation, Dr. DeCruz presentation, so that he can give us the brief idea of how to integrate the research, how he has done it in his experience.
Right.
Okay. And then I will just coordinate the questions about what other experts feel and how to go about the clinical research. How do we do it in our clinical practice? What are the things we face and how our colleagues?
Yeah, Dr. Mudit, we are live now.
Okay.
We are live now. Yeah.
So
good evening, everyone.
On behalf of the entire organizing team and the Paras hospitals, we welcome you all to the first Paras Cancer Conclave 2021. We are grateful to all the delegates for an overwhelming response with over 8,000 registrations from various countries, including India, Nepal, Sri Lanka, Kenya, Nigeria, US, as well as Europe. Apart from having onco-specific sessions, which is a usual norm in all oncology conferences, we have this time dedicated sessions for early diagnosis and intervention. Another important addition is the Meet the Expert session. We have one surgical, one medical, and one radiation expert on each of the days. So today we have with us Dr. De Cruz. He needs no introduction, and he's the director oncology at Apollo Hospitals. He has several awards, innumerable publications to his credit, several randomized practice changing trials, and none other than Dr. De Cruz could do justice to this topic, which is integrating research into clinical practice. And to moderate this session, we have Dr. Mudit Agarwal, who is a senior consultant head and neck surgical oncology at Rajiv Gandhi Hospital, Delhi. So over to you, sir and Dr. Mudit.
Sir, Dr. Anil?
Yes. Am
Sir,
I heard?
Yeah, you are very much heard, sir. It is a privilege and honor, sir, to be with you in this meeting, actually. And really, after the randomized trial, we really feel proud that you are among us, and you are made really proud of what we are there in international forum now. So it is a pleasure. I would like to invite you, and please give your comments or your expert opinions. And how do you feel coming from your Tata Hospital and now coming to Apollo Hospital, the research which you really feel should be done at each level by all clinicians, so that we can come much more forward, and Indians can come much more forward in clinical research. What do you say, sir? And we invite you for that, sir.
Thanks, Modit, for the kind words. I will be the same whether I'm in Tata's or Apollo. My passions are the same. But as I look at the screen, I can see a person who was an integral part of the study with me, Dr. Mitali. There she is smiling away. And it's great to have her as well. And she's changed into the private sector much before me. So we'll have her make some comments as well after that.
Definitely.
And we can stimulate a good discussion. So quickly, if I can say, I have put together a little talk. I'll try to run through it quickly to set the stage, and then we will go ahead, and it's integration of research in clinical practice. And this is what Ranga wanted me to do. When you look at clinical practice and research, people think they're opposite. They're opposite sides of the coin, that you either do one or you do the other. But to me, they're really the flip sides of the same coin. You must have clinical practice and research integrated into whatever you do, and that will impact on your outcomes. And there are many other benefits, which I'll tell you as I go along. Now, let's look at why and when we became doctors, we all took the Hippocrates Oath. And I've kind of underlined one of the lines in red. I will follow that system of regimen which, according to my ability and judgment, I consider for the benefit of my patient. So I want to do the best for my patient and not do harm. And we'll focus on cervical metastasis, which is the single most important prognostic factor. You have notes, survival decreases 50%. It grows a little more and comes out of the capsule, a further 50% drop. So management of cervical metastasis is of paramount importance. So I'm going to draw an example from cervical metastasis. Seminal publication, October 1990, by a very well-known head and neck personality that is known the world around. 1,119 radical neck dissections done from 1965 to 1986. 33.3% of these who had an R&D had micrometastasis. And look at the picture on the down, which tells you that more than half patients who have an R&D have shoulder dysfunction with significant impact on quality of life. Up to the 90s, people were doing R&D for micrometastasis in 1/3 of the overall population. Highly cited paper, despite the fact that though George Kreil described the radical neck in 1905, Hayes Martin at Memorial revamped it and gave new dimensions to the radical neck dissection. But look at 1926, if you look at the literature, Bartlett and Callender described an MND saving the structures, and Eduardo Suarez' first description of an effective modified neck dissection in the early 60s. Yet up to 1990, we continued to do the R&D. Look at the N0, something that's dear to my heart. In a state of clinical equipoise for more than 5 decades, I've just put studies here of various natures with different endpoints and look at the total number of patients, exactly the same in both studies. So some believed wait and watch was good, some believed elective neck dissection was good. Who's doing good for their patient, who's doing harm, we don't know. Till we came across with our practice changing trial and said, if you do the neck, 1 death is prevented for every 8 patients treated, and 1 recurrence is prevented for every 4 patients who were treated with an END. Practice changing, level 1 evidence, first publication globally in from head and neck surgery in the New England Journal of Medicine. What were people doing when they were waiting and watching? So if you look back at this slide, if you calculate the number of patients in the wait and watch arm across all these few studies I put up, there were 1,000 patients. And 125 deaths could have been prevented and 250 recurrence could have been prevented in the wait and watch group had they had a neck dissection. So I go back to Hippocrates' oath. Were we doing correct to our wait and watch arms? Or were we doing correct not doing a trial of R&D versus MND and subjecting micrometastasis to radical neck dissections? Contrast to our colleagues in breast, 2 large trials, NSABP 04, 06, 1971, 1980, that refuted the biological principles of aggressive Halsted surgery with greater emphasis on systemic therapy. You don't have a lady with a breast cancer treated anymore on the panel on your left. Breast conservation surgery is the norm. Now, these guys could have also gone across and continued to do a radical mastectomy into the 90s, but they did trials, telling you that you must do trials as literature evolves and you must challenge strong dogmas. And a nice quote from Richard Simmons, who's a surgeon. Commonplace clinical problems in surgery are approached in diametrically opposite ways by surgeons with similar training backgrounds, having read literature but interpreting the available information differently based on unique personal experience, vision, or surgical prejudice. So we interpret literature different, and if you don't have research in your practice, you'll still have patients going for the wait and watch approach. Here is a lovely paper from the NHS, a couple of years old, looking at colorectal cancers in the UK, which is a common cancer in that part of the world. Greater than 200,000 patients treated for colorectal cancer were analyzed. Centers that participate in clinical trials showed a lower post-operative mortality. Look at the p-value and the number of zeros. Improved survival, again note the p-values, and the effects were greater in centers with longer periods of participation in clinical trials. The second point I'm making, you have to do research, and the quicker you get into it, the better. It not only impacts on your patients on trials, there's something called the bystander effect. And other patients also improve because doctors, clinicians have improved and rationalized decision making. The institution then insists on evidence-based practice, and the institution and clinicians also explore newer treatment, regimens, and instrumentations. So another tangible benefit of being research. You not only give good care to your patients who are on trials, there's a bystander effect, you innovate, you practice evidence-based, and everybody benefits in your institutions. Now, a lot of y'all, and Mudit sent me a little mail saying, we have a lot of hassles, no money, we don't have this, we can't do trials. And it's really a myth. People believe trials are only done in America or Europe, only in the academic institutions like Tata Memorial Hospital. It's time consuming, it's costly, it's not for me. Is this true? I've put what is called the Akron study 2 years back in JCO. I just don't want to go into the studies, basically looking at PET in the N0 setting. 287 participants from 23 institutions in the US. A PET scan was done in 268 N0 neck sites of 210 participants. They have shown a high negative predictive value in the N0 setting based on SUV, published in JCO, caused a lot of debate and brought PET into the realm of imaging of the neck. Please tell me, Mudit, Mitali, all of y'all in private practice, if 10 of y'all all do PETs, you could easily have 300 patients in India for the N0 within 2 months across 5 private centers and have a great publication in the JCO and also change the way we image the N0 neck. You don't have to have some great ideas. Here's another New England Journal of Medicine publication, which I love. Topical 0.5% ivermectin lotion for the treatment of head lice. Head lice is so common in our country, yet this publication did not come. I mean, anybody could have done it within our country. So you don't need some great molecular targeted therapy trials. You can have a simple trial like this that can impact. So exactly the same in head and neck. There are just so many, and I'll share a few thoughts with you as we go along. And exactly the same with our randomized N0 trial. 2 simple arms, clinically, radiologically node negative, half went for elective neck, half went for wait and watch, New England publication. So you don't need some big molecular studies to do trials. It doesn't cost millions. In our randomized controls trial, we only spent 20 lakh rupees across the study. 1 dedicated trial coordinator, 1 fellow. I'm sure now Mitali will say that she was underpaid and that's why we only spent 20 lakhs. But truly, that was the pay at that point in time. So we didn't need millions to do these trials. If you have a simple question, thoughtfully crafted, you don't need millions to do a good trial. You don't have to be in great institutions. The first real randomized trial was the use of vitamin C in scurvy. And this was done by James Lind on board the ship. What did he do? He had 6 sailors, 2 in each group, who got different types of treatment: cider, vitriol, vinegar, seawater. The guys who got the 2 oranges and the lemon were the people who survived the voyage, and that's how we found out the treatment of scurvy with vitamin C. So you don't need fancy institutions. This was done on board the ship. So not too much money. You need a good question, and you can do it anywhere. You don't have to always do randomized trials. And there's a publication from Dr. Bavaskar. Both of us got an award together. I shared the dice with him, and that's why I have these slides up. He's done it in rural hospital in Maharashtra. All he did was audit his work well. He kind of looked at red scorpion sting bites in the region, which were very common. 2 publications in BMJ and in Lancet. By just monitoring the data and how he treated his patients. And I think any of us would give an arm and a length for these kind of publications. And years back, when he was so much younger, probably the age of all you youngsters are. So you can audit your work and come up with good publication. It gives you benefits of a definite audit plan. It improves patient outcomes. An audit can be national, hospital, patient-based, or you all can do it cumulatively as well and have some great data. Things are changing. And I always like to put this slide up, which I keep updating from time to time. The late 80s, early 90s was when I started my career. And you can see the publications from India and PubMed during those years. And I think we went around the length and breadth of this country. I see a great change. And you can now see the Manhattan or the sky slopes that you can see with the number of publications in our country increasing. And mind well, these are not only from one or two institutions, these are across the country. So I can see a big change coming, 7,237 publications. But you see the last couple of years, the huge jump in the number of publications. And it gives me great pleasure to present this, which I read 3-4 days back in the JCO from Lucknow. Responding to Garrel's trial of sentinel node biopsy versus elective neck dissection, it was a correspondence, but a very thoughtfully, simply written correspondence that found merit and came in the JCO. So congratulations to this whole group from Lucknow that have put it. And I believe the culture is percolating in our country. I believe gone are the days where one or two institutions has the monopoly. I think it's great for our patients, it's great for science, it's great for our country. And those are the benefits that I would urge all of you all to take research. Their personal gains, their department and institutional gains, their national gains, and their gains for your patients, the society, and mankind in general if you do research. And I've tried to tell you that you can do research anywhere with limited cost if you have the right question and the right attitude. And what better place to do it than in head and neck, which is the Indian cancer. For years, when I start in the audience as a young student stroke assistant surgeon, I always believed it was our cancer. 25 to 30% of all our cancers are head and neck. Yet we have foreigners coming to teach us how to treat head and neck. And I think it's such a shame. But over the years, I see a change. And today we have at least 100 youngsters who can stand abreast with anybody in the world and discuss head and neck treatment. And I just believe better times are yet to come. Some suggestions to the youngsters. You can do trials with survival as an endpoint, the N0 trial, the arrest trial. The Toprani group, the Amrita group are leading arrest trial. I know Sudhir from Tata's is part of it. You can do trials testing a regime of treatment like the CISPAT weekly versus 3 weekly, simple trial, JCO read by Vanita. I was part of this study as well. You can do cost-effective strategies, metronomic therapy versus immunotherapy targeted. It will impact the world. I know there are ongoing trials when I was there that started at the Tata Memorial. Probably we'll have the results very, very soon. You can do technology-related trials. IMRT, Chris Nutting's passport trial, when IMRT came, has so many citations, a Lancet publication, 200 odd patients. Same thing you can do, Mudit, with laser, with robot, with the proton, which is now considered or evolving into the standard of care. And there's so many more trials that we can think as we go along. I leave you all with my last slide that do trials, but good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. I see a changing trend, a positive trend, but I also see a group of individuals who sit on their computer and want to treat patients. That's not good enough. You have to sit on your computer, do the research, but you also need to have good clinical expertise. Either one of them is not enough. And this is a very, very popular quote from David Sackett. I use this slide very, very often. I'm ending with these initial thoughts. I'd love to have a discussion with the other panelists and the audience, and we can evolve what we can do for research in head and neck. Thank you, Aditi, Ranga, and the organizers for the opportunity to be part of this talk, an opportunity to be part of this great program. Thank you.
Thank you, sir. So I have just one question for you is, the scenario which you had in TMH, can you place yourself with a similar situation where now you are in a private sector? Would the things would have been different for you right now, counseling the patients, taking consents, and randomizing the patients?
So a very good question. I must confess that I've come into Apollo about June will be about 2 years since I joined. 8-9 months we lost because of COVID, when things were very, very slow, and everything went on the back foot. But my dream is to put a system in place. My dream is to set a department. And one of the reasons I joined, I could have done standalone practice in some of the fancier nursing homes like Breach Candy and things like that. But I joined a group to put this system in place. We are trying. The initial steps have been taken, and I'm very, very sure that it will fall into place in time to come if I have support of the management and others. But forget me, I just look at a Kaustubh Patel, Rajendra Toprani group. I mean, they do practice. They have high clients that they see. They have a decent practice. They put together a department. These guys teach. They also do research, and the ARREST trial, which is really looking at intermediate factors in oral cancer, they are one of the biggest contributors in terms of cases to randomize patients into whether they should get or not get. When you look at all pharma-funded trials, many of them come out of the private sector. Patients don't have a problem giving consent for that. So I think that if you have a will, you can do it. And I must tell you, Mudit, every time I come, I chair your scientific committee at the Rajiv Gandhi. And every time I come, your chairman tells me that I must invigorate you all to do more and more research. And I think Rajiv Gandhi is an exact or an ideal platform to really launch big time into practice. So I'd really urge you to think out of the box and do simple trials. You love robot. You can do something on robot. Between Surendra and you from Delhi, you all can have a great publication. Trust me. If you all to hire me, I'll help you all to do that publication.
I think there's a problem with
Tali, can we have you? And what do you? Hello?
Yeah, Dr. Mudit, are you there?
Hello?
Okay, I think sir got disconnected.
I'm here.
I'm okay. Am I
Yes,
heard?
sir is there. Yeah.
Yeah,
I think let's have Mitali's comments. Mitali?
Yeah. Can you
unmute yourself?
Unmute her?
Yeah, good evening, everyone. And as expected, it was a wonderful talk. Each time I hear Dr. D'Cruz, it's a different way of motivating myself. So yes, and I endorse every viewpoint that he made. Especially now, we know Dr. D'Cruz has a busy practice, and he is the president of the UICC. He is in a leadership position, and it is possible to practice as well as do clinical research.
Sir,
what's your viewpoint? Like when were you in Tata and now you're in private practice? How you see your scenes have changed of research when you were in TMH versus now you're in private practice? What do you say for it?
Okay, so a very a thing that I feel is, so Dr. D'Cruz would agree that I was involved in an integral part in consent taking of patients in Tatas as well. And let me tell you, the consenting, whether you're in Tatas, whether you're in the Paras group, or whether you're in any other private hospital, consenting process remains the same. I mean, these questions are unanswered. We do not really have the path as to which one of the two options is correct. And that's precisely why we are going to keep them into clinical practice, clinical trials. So it doesn't matter whether you're in a private hospital, a public hospital, an academic institute. Patient remains the same. The patient care remains the same. So I guess consenting should not be much of an issue. If the patient is convinced and he remains in your follow-up, I guess it's possible to enroll patients even in the private practice.
Okay. Dr. Piyush, can we have your view?
Yes, sir. I have basically, I heard Dr. D'Cruz, and I basically agree with the point that a single center in private setup, definitely few centers have a high volume to basically undertake a randomized control trial. But rest of the centers who don't have that much of volume can unite together, then they can combine their forces to work in that direction and have a decent study, because single center will not have adequate number of patients to reach a conclusion. So yes, multiple centers should basically come up together and basically take up at least in head neck cancers, because we are basically sitting at the seat of the head neck cancers.
Okay.
Sir, can I make a comment? I am
Yeah.
not a surgeon, but sir, talking about research, so I was also in Tata for 3 years, and now I am in private practice. So one thing that you were saying that we can club patients and then analyze data. Now, if you try to pick up patients, then the uniformity in investigations is sometimes not there, because some patient may be affording PET, some may not be affording PET. For some patients, CT would be done. For some, an MRI would be done. So that uniformity in analyzing the data does not come when we start analyzing our patients.
Because cost becomes a major factor in private sector.
Aditi, I'm going to respond to your question. Whenever you do a study, it's better that you'll decide on the factors that you want to capture before. And we need not do it for all patients. In your practice, at least 20, 30, 40% of patients will have all the investigations. But I'm going to draw your attention to a study that I did with Mitali. I'm wondering why she's keeping so quiet. And this was adherence to guidelines across various institutions in our country. And we did a monkey survey and we sent this questionnaire out to various doctors at various conferences, including Best of ASCO. And we found that for investigations, there was more than 90% compliance across institutions, more than 90% compliance across institutions. But when it came to treatment, there was a variation with community hospitals. Corporate hospitals may not comply as much as academic institutions. So in our country, sab log PET karate hai, even if the patient doesn't afford. In fact, I would say they do over investigation with PET. So I don't agree with you. I have patients who come with CT, MR, PET, and maybe some brain scan also when they come to see me with a simple buccal mucosa cancer. Where there is a will, there is a way. And we all have to change. We have to get together and do this study together. And I think associations, Paras Hospital, like this kind of a meeting, at the end, there should be a consensus. Who doesn't want to do a good study? Everybody wants their name in good journals. You ask anybody in corporate, they'll say we miss academics. And you ask people in academics, they say we miss the money.
Right.
Right.
I don't. Yeah, go ahead, Mitali.
Sir, I mean, sorry, continue. Please continue.
No, I was going to say that, Aditi, if there are any questions in the chat box, you can read them out. If anybody is listening to us and they want to ask any questions, but Mitali, go ahead.
So I just want to, as you said, we did a study on adherence to guidelines. We also did another survey-based study to look at the barriers of conducting clinical trials in the country. And similar to the previous study, we sent out surveys to, meetings like the Best of ASCO. Again, there it was mainly inertia, rather, the will that Dr. De Cruz is referring to actually conduct studies than there being actual problems. Like we saw various criteria as to whether there was adequate training, whether there were funds, protected time, all of which was, yes, it did score a little, but the maximum that really scored was a lack of adequate follow-up and unwillingness basically on the parts of the clinicians. So I guess all of us are at fault and we must make a concerted effort to do something.
So, Dr. Mitali, I would like to ask you, how do you manage your follow-up? Is it all recorded in your place? In private sector, that means either you're keeping a person with you who's keeping track of your follow-ups, or how do you manage your data? Because it's a data collection management is a big issue. If you want to do audit also, you need to capture all these data. So how do you do it? Can you give some tips about it?
Absolutely, Dr. Mudit. Maintaining data, like Dr. De Cruz was suggesting, all of us must maintain an audit. It helps us to improve our own performance improves when we keep an audit. And yes, it is not very easy for each one of us to have a person dedicated to us to keep our follow-ups. But I do make an effort. I do have an SPSS format where in each patient who is treated by me is entered right from the date of the first visit till the last follow-up. And yes, it takes time. It takes a lot of effort, but I managed to do it. I mean, that was one thing that I had learned it from wherever wherever I was before this. That is the Tata Memorial Hospital. And that was what all of us practice. Yes, we keep our data so that we know how each one of our patients is doing.
Okay.
Pavan has sent a message. Time in private is used to capture patients rather than do research. Pavan, very true. You in a way you are true. I won't deny it. But I want to tell you one thing, Pavan, that if you start doing niche area practice, you do some great trial on, say, infratemporal fossa clearance, or you do some trial on tracheal resections, or Mudit does in robot, patients will come to you. The news will go around your colleagues कि पवन तो बहुत उस्ताद है infratemporal में. Automatically the patient will come, and then you can do finer research in that. So I agree with you, but if you just take a little hit, a little bit, give dedicated time, it'll all fall into place.
That's true.
Yes, sir. I of course agree with you, but it was a general comment that this is how the time is utilized in private. Now that you are also in private, most of the time you are jumping around to doing more of promoting yourself, doing CME, which has no meaning, just to promote the commercial aspect of our. So
मुझे शर्मिंदा कर रहे हो ये बोल के. I am not here to promote myself today. I thought
not here.
Stimulate you to do research.
Yeah, of course. And sir, just to put it this way, I have been doing a lot of activities which have been like tobacco research, and a lot of new things have come up. Of course, I will be presenting it today. So this has been my effort for over many years on how to help people tobacco cessation, which has been a lot of efforts on my extra time and doing a lot of community work to get more and more patients. Now I have enrolled a lot of patients. And yes, I totally agree. If you have the will, you can do it. That's the ultimate what Dr. Anil has been saying and emphasizing, and I totally agree to that, because a lot of my time I get up early in the morning to do that part which I cannot do in the clinical setting, right? That is the research part, getting patients, how to connect with patients, doing the survey online. A lot of my surveys are going to come up very soon, which I have done with the doctors taking tobacco, what is their, why they are not ready to quit. So these are some of the things, sir. As sir has said, if you frame the right questions and put it there, we can do it. So I'm into it, sir. Thank you so much, sir. And it was just a general comment, nothing, not to hurt anyone.
No, it's okay. Be easy. That's how discussions evolve. Yeah, go ahead.
Sir, we have Dr. K. Pavitran. He's the head of the Department of Medical Oncology and Hematology at Amrita Kochi. So maybe we can have comments from him as well.
Can invite him. Yeah. Please unmute him and hello.
No, same has been said already. Yeah, in academic, definitely we have. It is all busy, but still we find out time to do some basic as well as clinical research. Basic in the sense that now in our campus itself, we have got the nanosciences. So they collaborated with us for the clinical questions, and we have designed few studies, and we are doing it. So as Dikru sir said, if there is a will, you can do it.
So I think what we have to think, what Dr. Anil Cruz was saying, was that we need to collate private institutions together. That's what I could get, that if to get great numbers and do good research, you can have people, we can have trial meetings or something like that. We can have it so that we have one question to answer, and 2-3 institutions like in Delhi. That's what we are trying to, we made a Delhi head and neck oncology group so that we can collate data with other people so that we can generate some data and have good studies. And we're trying to make one app also where we could include all head and neck, all the risk factors, normally what we record in pathology and clinical data, and then we share among us. But the thing was, there was there was an issue regarding the breach of data, that if you share among yourself, among the institution, that confidentiality of the patient should not be lost. So there was a great amount of issue regarding that. So we could not do that. So the sharing of the data, I don't know, sir, what do you say about that? Sharing of the data among the institutes, uh, does it have like Aadhaar cards also? They are saying that data has been lost by the government.
No. So your point is well taken that whenever you share data across institutions in public domain, you have to protect the identity of your patient. There's absolutely no doubt. But all of us have been part of so many trials, multi-centric, multinational, multi-institutional. We send data, but you mask the identity of your patient. There's absolutely no patient identifiers. And I think that is absolutely fine. To send across the Indian Ocean, you can't send biological material because people were sending and people misused it. So government has put a restriction. You need to go through the health ministry screening committee that meets every 3 to 6 months. And I think it's a fair decision because otherwise everybody was joining some foreign trials, basically giving us samples with no intellectual input. So I feel that's a fairly decent restriction that government has bought in. But there's absolutely no reason why you cannot share. You know, Mudit, I'll tell you, when I grew up, when I was your age, the divide between Tata Hospital and the rest of the country was tremendous. Today, when I finished training and I came back from the US, Delhi had no hospital. The biggest hospital was Gangaram Hospital. Apollo was just being built and they didn't have radiotherapy as well into the 90s. Then came Dharamshila and Batra. Today, as I say, Delhi mein gali mein radiotherapy and PET scan. I mean, Noida has maybe 5-10 setups. Gurgaon has 5-10 setups. Everybody has good institutions. The Apollo group across the entire group has 14 centers of excellence for oncology. So there's absolutely no reason why we shouldn't do. Whoever would think that Mitali would do great practice in Patna, today she has everything on her service. She does free flap, she does PET scan, she does MRI, she does CT, which never happened. Anybody in Patna would take the train to Mumbai. So that's all the more reason. Y'all guys are born in an opportune time. Make use of it.
Right, sir. So other thing, what we were trying, any suggestions regarding what happens that if you talk to in our Delhi, we talk to AIMS. So AIMS collaboration with the government institute, little bit it becomes an issue because the data and the time management is different as compared to private sector. Or is it only the will which we see, that what you're saying, point out that it's only the will which we don't have? That's why we're not able to go forward.
You need to have like-minded people together. Like Tatas may not collaborate with, say, a smaller center, but once they see a good trial coming, everybody will be part of it if the trial comes. So the arrest trial started with KK from Amrita Institute, and I kind of encouraged Sudhir to be a part of it when I was there because Sudhir had similar thoughts. So he's part of it. The Toprani group joined, and I think Shamit and a whole load of other people have also joined. I think you just need like-minded people. You don't have to get everybody. If you, Mitali, and me get along and we share the same concept, we share the same passion to answer a question, we can do a study together. That's it. I mean, you just see who believes. I mean, I may not join a robotic program because I'm not strong in robot, but someone else, Surendra, will join you. Maybe someone from Tata's will join you. You have to find like-minded people. Mitali, I saw your hand up, and one of the things I always fight with you about is that you have to come back into research and academia. So I want to hear what you're saying.
Just a small effort. I don't think it's a small effort. It's a big effort actually by the Paras cancer centers like Patna, Panchkula and Delhi. They have made an effort to bring together all Dr. Rangarao, who's the chairman of Paras Cancer Centers. He heads this initiative whereby all the joint clinics are done together. So this is a small effort to pull in all the cases together and make kind of, I mean, we can build up on it and make like kind of a database and take it forward if we have the will to go ahead. And a similar effort of the sort is also done by the National Cancer Grid. I think a lot of centers are a part of it, and that is another effort that has been made to collate data and do some impactful studies out of it. So that's one comment I thought.
So other word I would like to know about the funding part. So because doing a clinical trial or basic about the patient part, but if you want to go to if you want to study some molecular part of it, NGS you want to do it. So how to do that? Because here also what they say, if you collaborate with the medical oncologist, then you might get money, or about that government agency who fund them in private sector. It doesn't happen so frequently. So how do you think about it, sir?
So basically, we have a lot of funds within the country, ICMR funds, DBT funds, DST funds, but you're correct, they'll normally give it to government institutions, because government institutions have established credibility. They feel their money is safer if they give it to a Tata hospital or to an All India. And even doctors, clinicians, researchers in these institutions show more will than say someone at Paras or at Rajiv Gandhi or at some other private hospital, Max or Apollo or things like that. But having said that, you can always tie up with centers, like say you tie up with the NCBS in Bangalore that does a lot. In Delhi, you'll have so many basic centers. Someone who has the expertise to do your NGS. You catch a scientist there who has the expertise, share your thoughts, keep them as your co-PI, someone who has credibility and publications in that, and I'm sure you'll win the grant. And once you get the first grant, then there's never a problem. Then you'll always get a grant subsequently. Winning that first grant is a problem. I've sat out at the DBT committee when I was in my 40s. I mean, I was called to sit as one of the members on the DBT, and I realized that if you have a good thought, you have some credible names, and an institution to back you, the grant is easy to come by, because there's a scoring chart that is being done by. So I think you need to do that. And Pawan's put again, he's tied up with the Gujarat University. So here he is giving you proof how he's doing it out of the Max Center. I see Alok's on. If Alok wants to make some comments coming from All India.
Dr. Alok?
No, I didn't want to make any comment per se. But yeah, I just sort of logged in and was listening in. I agree with Anil on the fact that there is a fair amount of money available with the funding agencies, and a good proposal will always get funded. It's not so difficult. But yes, there has to be science in the proposal.
Yeah, that's true. Hello. Yeah. Hello.
We can hear you, Mudit. I think the time's up, so you'll have to conclude. And
okay. So, Dr. Aditi, thanks a lot, Dr. De Cruz, and all the Dr. Mitali, Dr. Piyush, Dr. Pavitran. I think it was nice listening to you, sir. And you have really motivated us. And I think by next meeting or somewhere we meet, we will try to collaborate in Delhi at least and try to produce some data. And that's what I think. And we have been, I was in Max that time, I was trying to collect all the 5 Maxes together so that we can attain one data. But sometimes it is not possible. At least first of all, we should start from ourselves only. Then we can tell other persons that we have to come together. So I thank you all, sir. It was nice listening to you. And I think in future, we will go forward as the sir has said. Thanks a lot, Dr. Aditi.
Thank you.
Thank you, sir. And thank you, Dr. Mudit. That was a wonderful discussion. And sir, I absolutely agree with you. There is some lack of will. When we come to private, that mindset of doing research is actually not there. So we think research can be done only in an academic institute, and private is not meant for such things. But then groups like Apollo or Max or Paras, like Dr. Mitali mentioned, we are doing that pan-Paras tumor board. We can definitely collate our data because we are under the same name of a hospital, which is one thing that would link us apart from a similar thought. So that was really thought-provoking, and thank you, sir. It was nice listening to you as always. And now we would move on to the next session. So we have around 433 people live in all the 4 halls, and I would request all the delegates to please put your questions in the chat box so that they can be put to the experts. And for the next session, I would like to invite Dr. K. Pavitran to chair the session, who is professor and head of Department of Medical Oncology and Hematology at Amitra Institute of Medical Sciences, Kochi. And we have Dr. Amitabh Malik, who is the Chief ENT at Paras Hospitals, Gurgaon. So the chairpersons would be inviting the speakers, and I would request the chairpersons to please keep a track of time. And sir, I would also request you to please stay because we have a panel discussion and we would need expert comments from you after that. Over to the chairpersons, please.
Yeah. So we'll go ahead with the next session. Thank you, Dr. Aditi, for the invitation. And the talk is on organ preservation in cancer larynx and hypopharynx by Dr. Alok Thakur from All India Institute of New Delhi. Dr. Alok, please.
So I think Dr. Alok's presentation would be played from backend. Technical team, can we please have the presentation? Dr. Alok would be available to answer questions.
Dr. Alok, he is not unmuted. Alok?
So hi, Alok Thakur here. I can't quite make the presentation, but it's already there with Dr. Agarwal and with the Paras group, so they are uploading that presentation.
Right, sir. We'll just upload it. Aram, can we have Dr. Alok's presentation, please?
Yes, ma'am. Yes, ma'am. Technical team, please upload the PPT.
Aram, you'll have to start the presentation. It's pre-recorded. Dr. Alok is there to take questions.
The volume on your presentation might be low.
Aram, can you please adjust the volume? Sir, would it be okay to speak if we keep changing the slides?
You'll have to
Sir,
give
would
me
you
5
be
minutes.
able
I'm in the
to?
process of boarding my flight, actually. So maybe you can, I think it's best to run it yourself.
Aditi, I'm just wondering if you should do the panel discussion while they get this in, because the entire program will get late otherwise. And maybe if Alok reaches his destination, he can give it to us live. That will be more meaningful and we can quiz him a bit.
So we'll start the panel discussion by the time the technical team figures out to play Dr. Alok's talk. So do we start the panel discussion? Technical team, can we please have the slides? Are you playing Dr. Alok's talk? Arham?
Yes, ma'am. Technical team is doing that. But unfortunately, voice is not coming. I don't know.
You can please figure it out, and by the time we can have the panel discussion.
Okay, ma'am. Okay, done. Sure. Yes, ma'am. You can start the panel discussion.
So, should I start sharing my screen?
Yes, ma'am.
Can you please play it from backend? Ram, can you please play my presentation?
Yes, ma'am. Yes, ma'am. Just.
So, for the panel discussion, actually, I've kept two cases focusing on early diagnosis and timely intervention. So, can we have the next slide, please? So, we have a wonderful panel with us. We have two surgical oncologists, head and neck surgeons. We have 4 ENT surgeons, Dr. Abhimanyu, Dr. Sanjay Khanna, Dr. Rashmi, and Dr. Vivek Sinha. Dr. Piyush and Dr. Mithali are surgical oncologists from the Paras team. Dr. Piyush is from Paras Gurgaon and Dr. Mithali is from Paras Patna. And we have two dental surgeons, Dr. Sagir and Dr. Shruti Khatana. So case 1 is a 46-year-old female. She presented to us with an ulcer in the right lateral border of tongue. There are no addictions or comorbidities. She had complaints of weight loss of 2 to 3 kg in last 3 months and difficulty in eating and swallowing. On examination, she was of well built, and on local examination, she had a proliferative lesion in right lateral border of tongue, which was 2 by 2 centimeter. Also, there was a small lymph node swelling at level 2, 1 by 1 centimeter, firm, mobile, and non-tender. Next slide, please. Dr. Abhimanyu or Dr. Sanjay, and if any of you can take this question, what would you do next for this patient? Dr. Abhimanyu or Dr. Sanjay, any of you can take this question? Dr. Abhimanyu, I think you have to unmute yourself. Okay, so can any of the other panelists take up this question? What would be your next step? How would you proceed?
So we will basically proceed with, first thing will be the biopsy to basically see what that ulcer exactly is.
Okay, and any opinion on the FNAC from the neck node?
If the primary is well visible, if it is an approach and we can take a biopsy, then the first thing is to take a biopsy from the primary.
Right. Next slide, please. Next.
But firstly, I would like to know what which
So a
side.
biopsy was done, which showed that it was a.
I'm sorry. Just a quick question.
This was oral tongue, lateral border of tongue.
No, that's fine. But we've gone on to biopsy. I don't think the examination is complete. We have to first, I mean, without putting a finger to that ulcer, all that the information that we've got is that there's an ulcer. The ulcer is 2 centimeters, but before you've done that, before you've palpated, you might find the induration is far more than the 2 centimeters. So it's very important to make that initial tumor map on the basis of your clinical examination. Similarly, the information given as regards the lymph node, it talked about a lymph node, but which side was it? That's also relevant. If we are when we are doing the staging. And yes, absolutely, we would like to get cytology and histology. There's no denying that. But I just wanted to stress upon the fact that very often our documentation is incomplete in the initial setting itself.
Your voice is breaking, Dr. Vivek. Your voice is breaking.
Oh, right. I merely stressed on the clinical examination and the documentation ab initio.
So I completely agree with you, Dr. Vivek. Your voice is breaking, but then the description of the ulcer and mapping of disease has to be properly done. So it was an ulcer on right lateral border of tongue that was 1 centimeter away from the tip, and there was associated induration of around 1 centimeters posteriorly and medially, and it was free from the floor of mouth. It was non-tender and with no bleeding on touch. And about the lymph node, it was a small lymph node, mobile, non-tender, with no associated skin changes, and it was firm in consistency, 1 by 1 centimeter at level 2.
On the right side.
So does that suffice now?
Yes.
So how would you proceed further? Yeah, right lateral border of tongue.
No, I'm talking about the lymph node. The lymph node was also on the right side.
So Dr. Piyush just mentioned about the biopsy. Pardon?
It's okay. I'll write. Please carry on.
Yes, it's on the ipsilateral side, right level 2. Yes. So would we proceed on to a biopsy, or would we attempt an FNAC from the lymph node? Dr. Piyush just mentioned that he would go ahead with biopsy of the primary. Dr. Vivek, would you differ here, or would you go in for an FNAC from the node? Or would that FNAC help you in deciding the further management?
Well, I think an FNAC is usually more convenient, depending on which kind of setup you are at. Very often, you would require at least a minor, procedure room for taking a biopsy. And FNAC is along with the set of investigations that you would be telling the patient while you're counseling, and you also get the report the following day. A biopsy involves taking a physical piece, which very often there are issues of consent, etc. So a lot depends on the particular kind of practice you are. But I think it is convenient to do an FNAC to begin with. But definitely, there's no doubt about it. A biopsy is essential. You would like to do a biopsy as well.
Mitali, go ahead and speak. I think
Right,
Aditi is frozen.
So a biopsy of the tongue was done, which showed a squamous cell carcinoma, right lateral border of tongue. An FNAC was not done for this patient. Can we have the next slide, please? So what next? Now we know there is an ulcer on the tongue. FNAC has not been done. It shows that the biopsy is positive for squamous cell carcinoma. So what imaging would you do for primary or for nodes? Dr. Rashmi or Dr. Vivek or Dr. Abhimanyu, who has not answered, any of you can take the question. Dr. Rashmi, are you there with us? Or maybe Dr. Vivek or Dr. Mitali, you can take this question.
Dr. Mitali, please, because I'm happy to speak. It's just that I don't think my audio is very good.
So, so this patient clearly has a lesion on a very accessible area of his head and neck. And so a biopsy is kind of irreplaceable and really doesn't need much of a bigger infrastructure than what an FNAC needs. So I agree with Dr. Piyush that yes, biopsy is the first step. In addition to that, you made a mention that the patient does not give any history of addictions. So I would also want to know whether there are any jagged teeth in her mouth which need to be addressed before or after, immediately after the surgery, because that would be the cause for a recurrence in no time. And thirdly, since the patient already has a lymph node, it is difficult to judge whether it is reactive or metastatic. Putting in a needle in addition to the biopsy really would not change my management majorly, but I would err towards doing an imaging in this patient, irrespective of the fact that she has just a 2 into 2 centimeter lesion, because that imaging would give me an understanding of the tongue, the depth of the invasion of the tongue, as well as give me an overview of the neck nodal status. So I would go for a contrast enhanced MRI of the face and neck, because an MRI would give me a better soft tissue delineation as opposed to a CT scan.
Right. So next slide, please. So that is what usually happens in clinic, that some kind of an imaging is absolutely necessary. MRI or CT, either one of them, but the soft tissue delineation is better with an MRI. And in very specific situations, an MRI would score over CT, and otherwise either of them would suffice for primary as well as for the nodes. So next slide, please. Now for the evaluation of nodes, can we have the next slide, please? Next slide, please. Okay, so what would any of the panelists can take up this question? Now, what would you do for evaluating distant metastasis? Would you need another investigation, a CT chest or a PET CT, or would this be sufficient? An imaging of face and neck be sufficient for you?
So, Dr. Aditi, as we have a node which is palpable, and we will take it because tongue lesion is almost 2 centimeter or more. Plus you said induration is there. So we will take it as a disease which is, plus the tongue is actually an unforgiving type of disease. The chances of it being metastatic are much more. So if we'll consider the node to be positive, I would rather go for PET CT rather than going for a chest CT. So basically it will help me in two things. First, it will be a baseline investigation which I can compare always further in terms of response to the treatment also.
You would go in for a PET CT?
Yes.
Okay, any difference of opinion here?
So yeah, a little bit of a difference of opinion. So we are talking about a 2 by 2 centimeter tongue lesion. We are talking about a 1 into 1 centimeter neck node. The probability that this patient would present with distant metastasis would be less than 10%. And in such a scenario, doing a PET CT for a T1 query N1 tongue lesion is not really a standard of care. As if you look at the NCCN guidelines, as of now, they recommend doing a distant metastasis workup when it is stage 3 or stage 4 cancer. So yes, tongue is unforgiving, but this particular patient, I would not mandate workup for distant metastasis.
Right. So next slide, please. So this is what the NCCN also says, that for patients who are loco-regionally advanced or who have multiple nodal disease or who are poorly differentiated, they could have distant metastasis, mostly lung, and that can be evaluated with a CECT chest. But a PET CT can be done, which is optional because it has good sensitivity for detection of nodal metastasis as well. Now, Dr. Sagir and Dr. Shruti, you are the dental surgeons. So would you prefer to have any kind of an imaging for this patient to evaluate the teeth, the dental hygiene?
Yes, ma'am. So I would suggest if the patient presents to us, as we said before the biopsy, as sir said, it would be very important to see the jagged teeth. So if there is any, most of the times, by the time we take a biopsy, we address the adjacent tooth. by the report comes, the lesion has sometimes regressed. So a lot of traumatic ulcers present with induration as well, surrounding inflammation. The other thing at this point would be to take an OPG, which is an orthopantogram X-ray, simple X-ray which can be done at this time, so that we can address any dental, RCTs or whatever has to be done in the same process. That's all.
Right. Right. Next slide, please. So it is usually not a common practice to send patients to the dental department prior to getting oncological practice, and only once we decide in clinic that they are supposed to get radiation and a dental prophylaxis comes into play. But as Dr. Shruti very rightly mentioned, that doing a dental imaging assessment of the dental health is very, very important, and it can be taken care in that perioperative period without wasting time at the time of adjuvant treatment. So can we have the next slide, please? Next slide, please. So she had this MRI of the face and neck, which had a right lateral border tongue lesion. It was heterogeneously enhancing, and there were no significant lymphadenopathy in the neck on MRI, which was suspicious of nodal involvement. Next slide, please. Next slide. Next slide, please. And her CT chest was done, so the CT chest was normal. So clinically, she becomes a stage T1 N0 M0. Can we have the next slide, please? So what would be the next plan of action for her? She's a clinically stage T1, no comorbidities, young female, node negative. Dr. Abhimanyu, Dr. Sanjay, Dr. Vivek, or Dr. Rashmi, any of you can take this question.
Right. Just want a little clarification. You said that there was no FN done for this patient, right?
Right, right.
Right. Well, if the node is clinically palpable and you've got an obvious lesion, on clinical grounds, you would call it N1 disease. I see that you on the in the MRI there were no nodes, so I assume that that is the reason why we've labeled it as N0, because
Right.
it has regressed. Is that correct? Because
So
other
it was not suspicious on radiology. It was having no contrast enhancement. The fatty hilum was preserved. So that was the reason of calling it N0, because radiologically it did not look like to be an involved node.
Right, but when there's an obvious lesion and in the draining area you've got a node, you wouldn't rely on a radiology alone to call it that's my understanding of the subject, to call it N0. It is N0 because it has regressed subsequently at the time of MRI. It's not N0 because there is no enhancement on radiology. That's my understanding on the subject. So if it was before the MRI, before the node is regressed, I would have labeled it as N1, T1 N1.
Any opinions of the panel on that? Yeah, Dr. Mithali, please go ahead.
So, any staging of oral cancers or for any cancer basically is clinico-radiological. So, on palpation, many a times, even if we probably palpate a normal person's neck, we would find some firm lymphadenopathy. And Dr. Aditi very categorically said it was 1 by 1 centimeter firm. So a patient with a tongue ulcer because of poor oral hygiene, dental hygiene, she most probably would have a reactive lymphadenopathy as well. Well, MRI is quite sensitive in detecting, like Dr. Aditi again mentioned, the characteristics of a nodal metastasis. So clinical radiological judgment together makes up what is a CTNM staging. So I agree with the fact that it is CT1 N0 M0. If after clinical radiological assessment, it conforms to an N0 status. And if it has regressed while doing an MRI, that it again proves that it was reactive in nature.
Right. So what would be the next step then? Can you have the next slide, please? So I don't think there would be any difference of opinion on that. All the surgeons would go in for a surgery. It's a small oral tongue lesion. So would the surgery be only for primary or for nodes as well? And if you would be dissecting the nodes, then what kind of a neck dissection would you choose to do? So any of the ENT surgeons can take up, ENT surgeons or the head neck surgeons, either of the surgeons can take up this question.
I think Dr. Mitali was part of the randomized control trial in which they gave an answer to this thing, whether you need to do the address the nodes or not. So I think she'll be the best person to basically give the answer.
Thanks, Dr. Piyush, for this kind consideration. But yeah, I don't think it's just about me or anyone else. I think it was level 1 evidence to show that doing elective neck dissection saved lives. So as of today, all patients with oral cancers, whether early or late, even in the N0 state, would mandate elective neck dissection. And to answer the next part of Dr. Aditi's question, what would be the extent of neck dissection? It would be level 1 to level 4. And we have the facility of a frozen section or an improv cytology in the Paris hospitals. So yes, we would subject our neck nodes to a frozen intraoperative frozen section, especially level 2 and level 3. And if they are negative, we will stop at that.
I agree with the same thing.
We have the next slide, please. So, as you already mentioned, the type of neck dissection, and when you do that, that question has been addressed. Next slide, please. So, any opinions on sentinel lymph node? You go in for a sentinel.
Is it on for me or Dr. Vivek? Please go ahead.
No.
Anyone.
That was my question. Is there any institution which is actually following? Because it is fairly, it requires a center with a high volume center with a lot of, infrastructure. I don't know of any institution in my knowledge over here where sentinel node is being used for decision.
So, Dr. Mitali, you can probably take this question then.
Yeah, so if you look at the best evidence that we have about sentinel lymph node biopsy in oral cancers is the SEND trial, which was a multi-institutional trial conducted in the UK. And even there, it suggests it was not a randomized trial. It was a prospective trial, and it showed that it has a very high negative predictive value. Having said that, so because it has not been compared in a randomized fashion, whether it can replace elective neck dissection, as of today, we really do not have level 1 evidence to suggest that sentinel lymph node biopsy is a standard of care. Considering the fact that, like Dr. Vivek suggested, we need immense infrastructure, it is a huge learning curve. So before we really embark upon it on a standard of care basis, we need robust evidence to show that it is superior or equal to an elective neck dissection.
Right. Next slide, please. So as Dr. Mitali very rightly said, the data is controversial. A direct comparison is lacking, though from cross study comparison, the survival rates are comparable, but its technique and expertise dependent, though it has a sensitivity of 95%, so it is not the standard of care. Next slide, please. So this patient underwent a wide local excision with frozen and a right MND. And the next question would be that what would be the points in the histopathology report that you would look for deciding what adjuvant treatment this patient needs? So any of these surgeons can take up. Dr. Vivek, Dr. Rashmi, Dr. Abhimanyu. Dr. Mitali or Dr. Piyush, I think there's a problem with Dr. Vivek's
No, I just thought I was speaking far too much. That's all. I would just say that I don't think in this kind of a scenario I would be looking at adjuvant really, because for a T2N0 where you've adequately addressed the neck as well. And there is nothing on histology. I don't think any adjuvant is really required.
Right. So these are the histopathology that the patient had after the surgery. It was a grade 2 squamous cell carcinoma, largest dimension 1.5 centimeter. The depth of invasion was 7 mm. No lymphovascular emboli, no perineural invasion, and 26 nodes dissected, all were negative. Next slide, please. So now looking at this report, would any of you want to refer the patient for any adjuvant treatment or still keep on observation? Any of you, I think, can take up this question. I think Dr. Sanjay, Dr. Rashmi, and Dr. Abhimanyu are not there.
Oh, okay. So, yeah, I agree with Dr. Vivek. The histopathology clearly does not mandate, but I would want more information on the status of the margins. Unfortunately, that was not mentioned. So if the margins were adequate in a multidisciplinary team, we would decide on observation of this patient.
Margins were adequate, yes, but Dr. Piyush, do you have any difference of
So
opinion?
the only concern regarding this was the depth of infiltration. And by that depth of infiltration, I think few centers are giving radiation as an adjuvant treatment because of the depth, that is 7 millimeter, because they take the depth as 6 millimeter above or below. So once it crosses 5 or 6 millimeter, few centers are basically giving radiation as an adjuvant treatment in these patients.
Right. Can we have the next slide, please? Next slide, please. So as Dr. Piyush said that few centers do opt on giving adjuvant radiation depending on the depth of invasion. So though there is no randomized data, as Dr. De Cruz was also mentioning, the ARREST trial is looking at these risk factors and recruiting patients to know whether giving adjuvant treatment actually has an impact on the outcomes or not. But few studies that say that there is an impact on overall survival as well as the loco-regional failure-free survival. So though this is an oral tongue early lesion, but because of one adverse factor, and tongue we all know is an aggressive disease, we do sometimes err on the side of giving adjuvant treatment as well for this kind of a patient. Next slide, please. Next slide. So this was the ARREST trial that we were talking about. Next slide, please. This is case 2. Now, if we have time for the next case, we can take up. Chairpersons, do we have time for the next case? I think Dr. Alok's talk and Dr. Pawan's talk are still take up.
I think Aditi, you're already running behind schedule. So I don't know. You want to take it up?
Okay. So maybe we can end here and can we have the last slide, please? So what I wanted to emphasize here was I had involved the dental surgeons in the next case more. So I wanted to give this message that team involvement is what helps us to bring out the best results for the patient. Early integration of the dental surgeons in the team, multimodal, yeah, that was the last slide. So a multi-modal treatment is many a times required, and only when the entire team is sitting together, we can take up the best decision for our patients. Be it just a surgical patient, early disease, but then that integration and the discussion in the team is required. So I would just like to end here and thank you all the panelists for being a wonderful panel. So I hand it over to the chairpersons now.
Okay, should I invite Dr. Alok for his talk right now, or
so technical team? Yeah, so if we are ready with Dr. Alok's presentation, we can have that. Otherwise, Dr. Pawan's presentation.
Yes, ma'am, we have ready.
Okay, so you can invite Dr. Alok. We have his presentation.
Dr. Alok, sir, you can go ahead with your presentation on organ preservation in CA larynx and hypopharynx.
Aram, can you please play it because Dr. Alok won't be speaking.
And sound will come in after 1 or 2 seconds.
Okay, so you can just maybe say the next slide.
Yes. Run next slide.
Aditi, I think the audio file is not working.
Param, the audio is not working. Have you checked the audio part of it?
Yes, ma'am. I have checked. Audio is working perfectly, but I don't know why.
Audio is not coming here. Can you just change slides? If the audio is not working, then
I'm just checking.
yeah, we can do Dr. Pavan's presentation if you want to take time.
I think we can start with Dr. Pawan's presentation. On the back end, they can basically feasibility of this presentation.
Param, can you stop sharing? We can have Dr. Pavan's. So Dr. Amitabh, you can invite Dr. Pavan.
Yeah. Dr. Pavan Gupta, sir, please go ahead with your presentation on tobacco de-addiction, sir. I don't think anybody's around here. Dr. Pavan, sir, can you hear me?
Dr. Pavan was there. For
Yes, sure. I can hear you, sir.
Yeah, he's very
Sir, please go ahead with your talk,
Just
sir.
give me a minute. Switch on.
Yeah, sure.
So thank you, Aditi, and thank you, Chairman Sir, Dr. Malik, for inviting me. And we have got our seniors, Dr. Anil D. Cruz, and other team members who are here. Thank you so much for inviting me for this exclusive presentation, which I have been making and where I have done a lot of research and a lot of activities on something what we have said, tobacco de-addiction. Right. So if you can allow me the screen share, yeah, I can share the screen. So I'll just put in there. This is, it's not moving. Just a minute.
Param, next slide, please.
No, are you sharing the screen or I am sharing the screen?
Okay, please give the share screen to Dr. Pavan.
Sorry, you have shared the screen. No,
this is your screen.
Technical team, please remove the screen.
Yeah, now Dr.
Yeah, so we'll be talking about tobacco de-addiction, meeting the unmet need, and that's what it is, because there is a lot of requirement, and these are some of the activities, some of the awards. Then the most important is some of the books that I have made. I'll be talking about that, and I am the convener of training in tobacco cessation at the all India level, and we have started this accredited course under the Gujarat University. This is a unique thing to have happened in India in the last 2 years, that there is for the first time such a accredited course has been launched. So I'll be depending I Can Care for this purpose, because we have done a lot of activities through I Can Care, which we started. And see, this is the WHO Empower. I will not go into the details, but this is something which have been working. I'll not, but offer help to quit. This was the challenge, and this was the challenge at all the places across the world. I have been to a number of conferences in various places overseas on tobacco cessation, tobacco, but what I found, there were a lot of challenges. And let me tell you, all this journey of tobacco cessation started in my practice when I would tell to the patient and would really get angry on them when they were not even quitting they were not quitting tobacco even after having a commando surgery or even laryngectomies. We have seen such thing happening. So the question really came up in my mind, why? What is that reason why these people are not actually quitting tobacco? So this is where I started working, and this became my passion. And this is, as Dr. Anil D. Cruz said earlier today, that you have to follow something, do something on that, and then the things will come up. So I've been working extensively in this, and I have come up with a solution which I'll be talking in the next 10 minutes. So the numbers, that what are the challenges? The challenges are the numbers who require tobacco cessation, understanding the pathology of tobacco addiction. That is one of the things which Most of the clinicians do not understand this and they are not working on that. The genetics of behavior, this is a newer thing that is coming up. The genetics, why some people are taking tobacco, why others are not taking. Lack of trained skilled manpower for tobacco cessation. Certified versus quacks. I would call a lot of people as quacks who are not trained into tobacco cessation, but just working on that. Social acceptability versus social outrage. I'll be talking a little bit on that. And the industry push, how much they're pushing this tobacco into the market, and the empowered people in the society. These are some of the areas where we'll be talking. So look at this big community problem. This is a big 5,500 people get into tobacco every day. 2 persons die every minute. 3,700 die every day. That is equivalent to 10 aeroplanes being crashed every day. And just look at the numbers when we talk about the number of deaths because of COVID, and it has caused so much of halagulla. So, but if you look at the number of people who look for tobacco cessation, almost 50% of this 27 crores of people who are into tobacco want to quit. And this is a study by GATS too, but unfortunately only 4% are able to quit at present. And there is a huge gap that needs to be filled. And this is the numbers, this is the number of patients, people who are taking tobacco. And of this, almost 50% of these patients would require quitting. And another thing I want to emphasize on this, almost 50% of these patients would have, when we do any tobacco workshops or camps, 50% of these patients who come to us, even in PSUs, and almost 50% of the patients who are taking tobacco will have some or the other lesions in the oral cavity. That is the pre-malignant lesions. And this is the tobacco push by the industry. You see, if these were not enough, the smoking forms and the smokeless forms, now the new things have come up, the vaping forms, that the ants, and this is causing a lot of problems in the society. And so this is what is the pathology, why people are not able to quit. So this is the pathology. So let me put it this way, tobacco is a disease and there is a pathology, and the pathology has been diagnosed. We know the pathology, now we need to have the treatment, and the treatment is also now available. So this is the pathology at the brain level, where we have got alpha-4 beta-2 receptors which increase in these patients who are into tobacco, and these are the receptors which actually are activated when these patients are taking tobacco, and which lights up or which increases the activity of the brain for these patients. And this is the T band, which was in my research work with at Gujarat University with Dr. Rakesh Rawal. I have borrowed this slide from him. So this actually, he found that there is a specific T band in these patients who are prone for tobacco disease. And this is one of the things which will be coming up very soon, and we'll have a lot of presentations of that. And this is what we call it a social acceptable custom, which is the biggest problem why people do not turn up for tobacco cessation. And now we have to convert it into a social outrage. So this is what is happening. The quitting tobacco is made complicated, made complicated by the various traditional methods that is being used in the society, like pledges at the temple, dikshas with the gurus, and teri kasam on the wife, and then taking appointment with quacks. The quacks maybe, the train or the so-called even MCH in surgical oncology, or MCH or DMs in medical oncology, but they do not understand tobacco cessation, which is a complex disease. So I put them as quacks when it comes to tobacco cessation, because one needs to learn that. So I have one very important slide that I usually put whenever I have professional presentation, the responsibility of health professionals. It is inconsistent to provide health care and at the same time remain silent or inactive about a major health risk. This is the major health risk that we are talking about, the tobacco. The tobacco cessation is an important component of any therapy, whether it is cardiology, whether it is respiratory pulmonology, whether it is stroke, the neurology, and whether it is oncology. Tobacco cessation is an important component, and this is where the health professionals are responsible. So how do we address the challenge? This is my work, and I will quickly go through it. So in a comprehensive and addressing the challenge in the comprehensive manner, and that is what I said. So today's demon of the present era is the tobacco, and I need not talk about it, but what I launched was a Save the Youth campaign. That is sensitization, assistance, volunteer training, and enforcement. I'll just put this slide. So sensitization, what I started was a Be Smart, Do Not Start. This was a school program, and this is a community program that I started. So getting into the community and working with the colleagues, the doctors, the professionals, and also with our oncosurgeons, this is where I started working. So this was sensitization program. Be smart, do not start. Be careful and fearful. I have put this as be careful and fearful of the secondhand smoking. This is very important because secondhand also kills. And the Win Over Tobacco made easy for those people who need to quit tobacco. We have made this program like assistance program for them that is easy, and we have started a quitline, national quitline number, an app has been launched, books are there, online cessation methods, cessation centers, online group counseling, and we look forward for starting or setting up multiple online tobacco cessation centers are all major hospitals. This is where I'm really working, and of course I need funding for that. So these are the volunteer training programs. I'll be volunteers, marshals, ambassadors, alliance partners, and specialists. These are the programs, and we are training them as marshals and specialists and ambassadors. So, and then comes the enforcement, like enforcing tobacco cessation, enforcing tobacco-free zones at smaller places, in small clubs, institutions. This is how we started working, so that each pocket will have tobacco cessation or tobacco-free zones. So to make it happen, I wrote number of books because I could not get books in the market which will cater or which will actually help people in India. We were getting a lot of books which were in the Western, in the US or UK, but when it came to Indian way or Indian understanding, they were not. So I wrote each book for each purpose, like sensitization. I wrote this book, Be Smart, Do Not Start. Now it has been converted into 5 languages that assist the We Know Tobacco Made Easy. It is in Hindi and English. Then tobacco cessation we are giving for the training program, and then to how to make an institution tobacco free, which is a huge challenge we are trying to face. So these are the ways the volunteers, the marshals, the ambassadors, and the specialists, we are training. We have started this academy, training skilled professionals, and it has been endorsed by Gujarat University. This is what to build up the manpower, skill up, and create the visibility and networking. And this is the complex way how it has to be done. Tobacco cessation is not easy. It's not like anything like helping or for the blood or for like treating any specific disease like fever. It needs medications, it needs the behavioral intervention, it needs withdrawal symptoms management, associated illness management, immunity. So it has to be protocol based, it has to be personalized. So this is where we have started simplify, amplify. This is what we are doing. And the most people end up fighting and not winning over tobacco habit. And because tobacco is a disease and it needs to be properly done. So tobacco, the clinician's responsibility is that tobacco users don't plan to fail, but most fail to plan. There is a lot of relapses for these patients. And I have put this very clearly. It's a clinician's responsibility. Clinicians have a professional obligation to address tobacco use and can have an important role in helping patients plan for their quit attempts. So this is the cessation cycle: quantitative assessment, screening, behavioral counseling, pharmacotherapy, medicines, comorbidity, and then follow-up of this patient is important. What we have launched is a very unique app, which I'll request everyone to go to that. Just go to the Android Play Store and download an I Can Care app, which has got all the programs which is required. And it has got 2 parts. One is part for the public, which is free of cost. And the second part is for the doctors who can learn on that. So this is specifically technology has been added to make it simple and straight. And these are some of the things that we have tried to, the commonest problem, that is submucosal fibrosis, for which we started this, we introduced, this was a research product that we made where it has got a scale, and this is the opening device where we can measure the trismus and also help the patients to open up their mouth. So this is a Tris Care by I Can Care, which has been developed again at Gujarat University. And we help this patient. It has been quite effective in my clinical practice, and I'm sure all of you would like to have it in your clinical practice. So this is the uniqueness. We have got each and everything. I've already told about it. And we also started with e-pharmacy so that people can get the medications at their doorsteps. And this is what we have started with: the Quit Coach, Quit Buddies, e-pharmacy, books, and everything, the Quitline, the e-commerce. And what we need is the manpower. And this is what we need. Everything is ready. We need the manpower. We need the tobacco marshals in the society. We need the tobacco ambassadors. We need the tobacco specialists who are to be the doctors who can work on that. And there is a huge army which is required. I need not say that 26 crore people of these 13 crore people needing tobacco cessation. So the technology has been put by our team at Icon Care. The app is there, the online games are there, cessation intervention programs are there, group intervention programs are there. And what we have started is the setting up of the tobacco wellness centers. And this was the first center we opened in any corporate hospital across India. None of the centers have this facility. This is the first center at Max Vaishali, and now we are ready to have this thing. And we started creating this networking system. And this is what it is: tobacco marshals, tobacco specialists, tobacco ambassadors, tobacco volunteers. And we have already trained, and we look forward to train 1 lakh tobacco marshals very soon, and specialists, and volunteers, So it has to become a social outrage. People have to stop, and those who do not take tobacco have to look or frown at the people who take tobacco, so that they would start thinking of going into tobacco cessation. So these are again, I iterate, every one of you can join in, and we need to have it. So be careful and fearful. Refuse to take tobacco. Refuse to be a friend of a tobacco user. Refuse to marry a tobacco user. Refuse to employ a tobacco user, and refuse to work with a tobacco user. And this is what I'm insisting to the public, and this is where it is working. So there is a huge opportunity. Numbers are huge, good investment for any hospital, because if the corporate, they look at the ROI, so this is a good opportunity, because there are all the patients, all the 60% of the patients who come to the hospital need tobacco cessation. Technology aid is there and shows results. Training in place, skill up practice is there. We have got all the protocol, we have got training in place. Tobacco cessation is a complex and intensive. Refer to the right specialist. Please do not put your head into that. Refer to the right person. Visibility of a cessation program is a must, because if you start a cessation program, your own colleagues need to know about it. Network with community, create marshals and ambassadors. This will not only increase your professional networking, but it will help the society as well. So the last slide: tobacco cessation program to be given visibility and priority, certified manpower to be employed, implementation to be enforced, and should not be just for the namesake. It should be enforced, and it should be properly done. So let's adopt this Save the Youth campaign in totality, and a lot of money and lot of lives can be saved. So clean, green, healthy, and lively India, this is what we look forward for. So these are just contact numbers. Thank you so much. So let's protect the young ones. Let's join to make the Save the Youth Day campaign throughout India. Thank you.
Thank you, Dr. Pawan Gupta. Thank you for the remarkable effort you are making towards de-addiction. Can you hear me, sir?
Yes, of course, sir.
Yeah.
Yes, sir, I can hear you.
I think, yeah. And if there are any questions, I don't see so many in the chat box.
Sir,
So,
shall we play Dr. Alok Thakkar's?
Yeah, we can go ahead and do that. Yeah.
So if there is any question, I'll be happy to take it. Just put it in the chat box. I'm still available here, because lack of time, I don't think I can take it directly here. So I'll be happy to have many of you to join this program. I'm sure a lot will think about it. Thank you so much.
Thank you, sir.
Thanks for the opportunity.
Shall we play Dr. Alok Thakkar's video now, sir?
Yes, please go ahead.
Okay. Okay, sir. Okay.
So good evening. I'm Alok Thakkar, and I'll be speaking to you about how treatment for cancer larynx and hypopharynx has changed over the last few decades, and how we focus now more today, not only on curing the patient, but also in preserving the function. So this is how we used to do things. This is about 20 years ago, when we looked at our data in the late 1990s. And what you can see out here is that both for cancer larynx and also for cancer hypopharynx, it's an eminently curable cancer. So for stage 1 and 2 cancer larynx, you can expect cure rates in the region of 90% and 80%. And for hypopharynx, it's not all that good, but nevertheless reasonable cure rates. However, these cure rates have been taken at a time when our focus was primarily on cure, and organ preservation was a little bit of a less of a priority. Today we look at balancing both the cure and organ preservation. And this is the need of the society. A deformity-free neck and normal respiration and of course normal voice are very much part and parcel of what is required in modern society by our patients. And this has led to some change. So, as I said, it's about balancing cure and preservation of function. And when we look at preservation of function, we look at preservation of swallowing, aspiration-free swallowing. That's most important. If you can't swallow without aspirating, and if you can't swallow without keeping the food from going down your chest, then of course that's life-threatening. So that is number one. You have to preserve the airway, which means that you need to have a patient who's tracheostoma free, and then of course you have to preserve phonation or speech. When we were looking at cure, age was important and is important because cure rates in a large measure depend not only on T stage but more so on end stage. So as patients get progressively worse nodal metastasis, their cure rates tend to fall, and cure rates tend to correlate with stage, T and N. If you look at preservation of function, the nodal status is not all that important, and it is about the T stage alone. So patients who are in T1, T2, that is their mobile cords, are eminently curable with preservation of function. T3 stage, which basically means patients who have gone on to have significant lateral spread or deep spread and often with a fixed vocal fold, are often amenable to organ preservation today. Was not the case previously, but today they are often. And T4, occasionally we still can preserve function. This is a favorite slide of mine. What you see out here has been how advances in medicine and advances in our understanding of the larynx and treatment of the larynx has impacted over the years. What advances have impacted? You see that it was the linear accelerator in terms of radiation delivery and of course partial laryngectomy techniques and the laser, which were making a difference. Now, treatments which are focused on the larynx per se. What has really made a difference is just advancement in general radiology and advancement in chemotherapy with regard to getting more potent drugs and also getting to understand as to when is the best time to use them. By that, I mean the VA trial and the RTOG trial, and I'll come to that as we go on. So how is scanning impacted? Scanning has allowed us to assess tumors and their depth. We could not quite assess them previously and had to surmise as to how deep this tumor could be. Today with scanning, we can see there's extension into the pre-epiglottic space, extension into the paraglottic space, and extension outside the larynx. These were not easily detected clinically. And what this has meant is that tumors which we initially thought were early stage, when we do radiology, we find they're a little bit more advanced than what we had thought. And that has led to a general upstaging in terms of what used to be staged as T2 now often being staged as T3, and what used to be staged as T3 now often being staged as T4. Because by radiology, we can detect the depth of invasion, which we could not affect by clinical evaluation alone. What has also changed is our ability to assess these tumors in the superficial extent. So what you see here is stroboscopy. Stroboscopy actually evaluates how the mucosa of the vocal folds moves over the vocal ligament, and you can see it vibrating on the vocal ligament. And this is narrowband imaging, and what narrowband imaging, which is the picture that you see here in the greens, is telling you is the vascular loops in the deep submucosa of the larynx. And what this really helps us is in assessing or getting a better understanding of the submucosal spread of tumor. So if you see here in the central picture or the picture marked A, then you don't quite see as much extension that you can see when you look at the picture marked B, because you can see these loops in the submucosa, and this tells you that there is far more disease than you had initially imagined. So we have gained in our assessment, in our ability to assess tumors both deep and superficial extent. With this knowledge, today, how do we treat this patient? So this is the earliest cancer glottis, one that both radiation therapists and surgeons are keen to get their hands on because cure rates are so excellently good. And for T1 lesions, we'll tend to look at either radiation therapy or a transoral laser surgical operation. The other partial laryngectomy operations are talked about, listed, but not quite applicable because here the laser is the best option really if you have to treat. So what you see here is a patient who has a lesion in the right middle cord, and we are looking inside the patient under general anesthesia with the endotracheal tube. And now when you look at this with narrow band imaging, you see that the tumor is extending more anterior than you had thought. So what NPI has allowed us to do is to assess tumors a little bit better, and naturally that has improved our ability to get resection-free excision and improve cure. What you see here is how we do these resections with the laser, and what you can see is that this is a eminently simple operation done with the right tool, and if it's a superficial tumor as assessed by strobe, and if it's a superficial tumor, then you can get this out with very little morbidity. And the laser resection offers many advantages as listed on the right. So it's a single surgical treatment rather than 7 weeks of radiation therapy. It avoids over-treatment because with radiation you give the same 70 gray even if it's a more deeper tumor or if it's a more superficial tumor. While the laser you can actually do different resections depending on whether it's superficial or deep. And of course there's no long-term morbidity as occurs with radiation. The functional results are reported as equivalent. And more importantly, with the laser, it's not that you can't repeat the treatment as it's with radiation. You can do the laser, and if need, you can always go back and do again. In fact, with the laser, recurrent excisions are very much part and parcel of the treatment strategy because the surgical option is really built at resecting minimally with very good assessment under the microscope, because this is done as a operation under the microscope, and assessment with narrow band imaging. So close margin excision sometimes need re-excision. And as you can see here, these are the results that AIMS published recently. For T1 lesions with the mid-quarter lesion, you can expect 100% cure rate with some patients. This is the data from the US. It's retrospective data, but a huge data on 10,000 plus patients. And what it tells you that both radiation and surgery have almost equivalent rates. And of course, all of these patients are having voice and organ and swallowing preservation. So this is really a situation where you can have both cure and organ preservation in almost every patient. But as it gets to a little bit more extensive tumors getting onto the anterior commissure, or tumors which are a little bit more deeper, as you see here, there's a bulge which is going laterally under the false cords. The scans also show that there is either cartilage erosion in the anterior region, really more of a T4 lesion. Some T1 lesions can actually cause thyroid cartilage invasion and actually become T4 or paraglottic spread. So these are not quite the same as the patients we have been seeing so far, the T1 patients. These are patients a little bit more extensive, and for these patients, we don't restrict ourselves to laser resection alone, but also look at the partial laryngectomy option. What the evidence tells us is that both laser and radiation therapy tend to give you results in the range of 70-75% cure rates with organ preservation, but fairly equivalent. So you can choose which one you take on these ones. And though there is no head with vertical partial laryngectomy, the results that have come out with vertical partial laryngectomy in very large series actually tell you that you can get results up to 90% even in the T2 lesion if they're treated with an appropriate partial laryngectomy. So probably this is the best way to treat patients, which again offers patients both organ preservation and cure. And you can treat these patients and expect cure and organ preservation in about 90%. Glottis. Supraglottis, not so good cure rates, primarily because the propensity for extension to the neck nodes a little bit higher, and that impacts significantly on cure rates. But organ preservation is easier to obtain in supraglottic lesions. What you see out there is a lesion of the epiglottis, and these can easily be treated surgically and radiation treatment wise with an expectation of organ. This is the best evidence for supraglottic tumors, and what basically tells you that surgical treatment may offer a little bit better outcome than radiation treatment alone. So if you look at these situations, then both radiation and surgery are about equivalent. But when you start coming to supraglottic lesions and when you're coming to start to T2 lesions, then perhaps surgery starts to score over radiation as it is currently. When we look at what happens in the community, then radiation therapy continues to be standard treatment even for T2 lesions. The reason for this is obviously that choosing a treatment for a particular patient depends not only on a blind reading of the evidence as exists, but also on clinical judgment, also on patients' own preferences, also on the experience and capabilities of treating teams. And it is true that much of the expertise and equipment that you need for organ preserving surgery of the larynx is not universally available yet. So it is certainly very acceptable, and the recommendation in many situations is for these patients to be treated with radiation therapy rather than with surgery. Both remain good treatments. Both can give an expectation of both. But really, it is up to the tumor board that these patients should go to. And a tumor board, you can have assessments which look not only at the evidence as it exists, but into tumor factors and patient factors, because these are all important. Because certainly there are different subsites where one is far more comfortable with surgical resection than in other subsites. For example, if it's in the erythenoid, or if it's in the, as you see here, or if it's in the subglottis, then surgical organ preservation is more likely to cause complications. If somebody has poor pulmonary function, then again, even a minor risk of aspiration may not be worth taking. And if somebody has a great requirement on voice, and many patients today have a great requirement on voice, then perhaps radiation may offer a little bit of an advantage compared to very deep laser resections. And it is putting this all together that expert opinion can be had, and a tumor board can opine on what is best treatment for a particular patient.
Dr. Alok? Dr. Alok?
Actually, this is a pre-recorded talk.
Okay, so fine. Then we'll have to stop the talk as you already overshot the time.
Aram, how much is left?
I don't think much must have been left. It's already 15 minutes up. There can't be too much left after this.
So now let's go on to look at how we treat more advanced tumors. So going on to the T3 tumors. So T3 tumors is how things used to be. T3 tumor is ideally a tumor which is causing one part of the vocal cord, one hemilarynx being fixed, immobile vocal cord and erythenoid on the right side in this video as you see, but no cartilage erosion. And when we looked at the data many years ago, this was a very well quoted paper, which was quoted even by the yearbook of otolaryngology and head neck surgery many, many years ago. But what this really tells you that when it comes to T3, and you look at T3 treated by radiation alone, then the 48 months the disease-free survival with radiotherapy alone was only 37%. And if you did radiotherapy and all the patients who failed subsequently had salvage surgery, even then you didn't quite do as well, and you had a 65% survival with only 37% preserving their larynges. This compares not very well, rather compares rather poorly with someone who's had a total laryngectomy with radiation, where you can expect a 80% survival. So this choice between cure and organ preservation became stark in the T3 situation. And in previous years, it was generally quite standard. Today, there is a little bit more sophistication, which has come in primarily by the CT scan in view. So what you can look at today is that there are many kinds of T3. There are patients who used to be called T2 but are today T3, either because of pre-epiglottic space invasion or paraglottic space invasion. So this is a supraglottic tumor with mobile cords, but a T3 tumor. This is a glottic tumor with mobile cord, but a T3 tumor. And then there is the other set of T3 tumors which have fixed vocal cords, such as you see here, or post-trichoid extension, or wherein even a little bit of cartilage erosion, as you may see here. So different treatments for different situations, And generally, I would say that what you see here in patients which can be treated with organ preservation quite effectively by surgical treatments alone, which is a great way of going forward. And what is really in the darker font is about situations wherein surgical organ preservation doesn't seem sensible. You can look at radiation alone, but perhaps you can now also look at chemoradiation or concurrent chemoradiation, which improves the organ preservation in these patients. So as I said, if you have radiological, paraglottic, or pre-epiglottic space, think of surgical organ preservation. It is very much.
Dr. Aditi, do you want to stop the presentation or do you want to go ahead with it?
I think there's some technical issue. The voice is lost.
20 minutes.
Voice is lost.
Aditi, we have already overshot by 20 minutes. I suppose.
Yeah, so we can have quick comments from the chairpersons. Both the chairpersons and Dr. De Cruz is there to summarize the talks as well as the panel, and then we'll move on to the lung session.
I think Dr. De Cruz should be doing that. You want? Is he there?
Sir, are you there?
No, I think he's not there.
Okay, so we start with the first talk. We start. Where do we start?
Yeah, you can just summarize briefly for a take-home message, and then we'll move on.
So take-home message as far as Dr. Alok Thakkar's talk was there was, if you have a T1 lesion, you can go in for a laser surgery. If you have a T2, you can go in for a laser or a radiotherapy. And T3 surgery scores over radiation, you can have a concurrent surgery with chemoradiation. As far as the case presentation which we had, an early tongue lesion, the investigation of choice would be a biopsy followed by an MRI neck to tell you the depth of involvement and the soft tissue involvement. The treatment in any tongue lesion would require primary excision with neck dissection from level 1 to 4. And if there is no perineural invasion, there is no extracapsular invasion, you can avoid post-op radiation. Also, if the depth of invasion is more than 5 millimeters, then one should have post-op radiation as well. That's about it. Is there anything else, Aditi?
Thank you so much, Dr. Amitabh and Dr. Pavitran. So we are already running late in time, so without wasting any time, and I would want to thank all the chairpersons, all the panelists and the speakers. It was a wonderful session, and we have around 800 delegates watching us live, and it is being streamed live on YouTube. So I would hand over now to Dr. Piyush, who will be the session coordinator for the next session for lung. Over to you, Dr. Piyush.
Thank you, Dr.
Thank you, Aditi.
Thank you,
So,
Doctor.
again, good evening, everybody. I welcome all the delegates to the next session on the lung cancer. So, first and foremost thing that we have almost more than 8,000 registrations for this conference, and I thank all the people who have taken out time to register for the conference. Plus, right now, more than 800 people are doctors are basically attached with us at this particular point. So I would like to thank them also. Plus, I would like to extend the invitation for the day 2, that is tomorrow at the same time. There will be multiple more sessions and new things to learn. So now for this session, I like to invite the chairperson of the session, Dr. R.R. Datta, sir, who is head general medicine at Paras Hospital, Gurgaon. Dr. Ashish Agrawal, unfortunately, will not be able to join. Dr. Abhay Sood, who is from Karnal, will be joining us soon. So I'll hand over the things to proceedings to Dr. Datta. Dr. Datta.
Sir, he is not here right now. Sir, you can invite the first speaker.
I'll just invite the speaker. So for the first session, I'll invite Dr. Abhishek Anand, who will be talking on the biopsy in the lung cancer. Tissue is an issue. So I'll hand over the session to Dr. Abhishek, please.
Dr. Abhishek, we would request you to be sticking to time, please.
Dr.
Thank you
Abhishek.
so much for the invite. Can I share my slides?
Yeah, sure. Start.
Right. So a very good evening to all of you. And I will be discussing on the tissue is an issue in lung cancer. And in our day-to-day routine practice, we many times we face this issue that a patient with a lung cancer in advanced stage has come to us and biopsy has been done somewhere else. And then we just plan for IHC or maybe any molecular profiling for those patients. Then the report comes as tissue is insufficient. Kindly repeat the biopsy. So this is what we face most of the time. So let us find out how we can overcome this situation in our next 8 to 10 minutes of talk. So we will be discussing on what is the adequate method for getting a biopsy from lung tissue. What is the strategic management for small tissue whenever we are getting a small tissue biopsy? How to just go with this tissue in pathological testing or molecular profiling so that we can get maximum out of the small tissue? What is the streamlining workflow for IHC and molecular testing, and why there is need for multidisciplinary team to optimize the yield of any small tissue biopsy from the lung cancer? So if we go back 20 years from now, lung cancer was divided into small cell and non-small cell lung cancer. And non-small cell lung cancer were further subdivided into adenocarcinoma and the squamous cell carcinoma. But now, in the present scenario, lung cancer has been divided into multiple various subtypes based on the molecular profiling or the molecular aberrations. So we have now EGFR, ALK, ROS1, MET, HER2, and many different mutations present in the lung cancer, especially in the adenocarcinoma variant, and based on which we can give certain molecular therapy or the targetable target therapy to these patients, which is far much better than compared to the chemotherapy in the giving better survival to these patients. So this is the journey of a tissue sample. Sample, of course, need to be collected and fixed in the formalin. Then comes the tissue processing. Then the tissue is stained with the H&E staining, and if required, IHC is done, and the molecular testing for the actionable mutation are tested. And finally comes the report of these tests, based on which any clinician gives the decision for further management of any advanced lung cancer patients. So these are the indications for image guided biopsy: a new or enlarging solitary nodule mass, multiple nodules in a patient without known neoplastic disease or in prolonged remission, focal parenchymal infiltrates in which an infectious organism cannot be isolated, diagnosis of a hilar mass through negative bronchoscopy, undiagnosed mediastinal mass, and biopsy or a rebiopsy of a malignancy for targeted therapy. So many times we see a patient on targeted therapy is progressed, and we need to repeat the biopsy to see whether the actionable mutation is present or we have got any other new mutation in those patients. So lung biopsy can be divided into percutaneously or the image guided biopsy, bronchoscope guided biopsy, or the open surgery. If we talk about the image guided techniques, we have ultrasound guided, CT guided, and of course we have the fluoroscopy guided, which gives the real time image along with the CT guidance. USG guided biopsy is also real time monitoring biopsy, and the benefit is that there is no radiation exposure to the patients as well as the operator. And one demerit of this is there it is limited only to the superficial lesions adjacent to the chest wall or the pleura. So if we have a lesion within 3 to 5 centimeter of the pleura or the chest wall, then USG guided will be the best option. However, if it is beyond that, then we should be going ahead with the CT guided biopsy. So CT guided biopsy is the preferred guidance method for lung tumor biopsy, and it is because of the optimal spatial and the contrast resolution, as well as its 3D imaging ability. The contrast enhanced CT guidance differentiate the target lesions from the atelectasis, necrosis, and the vascular structures. And these are the indication for the CT guidance biopsy. This is almost the same as we discussed in our previous slide. So this image shows the CT guided lung biopsy. You can see the needle advancing through the lung parenchyma, and you can see the tip of the needle in the center of the tumor. So there are technical advancement in the CT guided technique as well, like CT fluoroscopy guidance that allows for real-time monitoring of the lesion movement. And there have been recent data that suggests that augmented reality and the robotic platform can be used in doing the lung biopsy. Wherever available, we had to do PET CT before doing the biopsy to get the to know the active lesion by the FDG uptake. So the complications are as expected, pneumothorax, which is seen in 5 to 50% of the patients. But however, most of the pneumothorax are mild and self-resolving. Pulmonary hemorrhage is seen in 5 to 15% of the cases. Hemothorax is seen in 1 to 5% of the patients undergoing lung biopsy. And there have been the case reports of tumor seeding along the needle tract, cardiac tamponade, and the infection converting into the empyema. However, these are only the case report and the theoretical side effects we don't see in our regular practice. Bronchoscopic guided biopsy is the second very common technique to do the lung biopsy. However, it is useful for the proximal endobronchial lesions only. And because we do not penetrate the pleura by bronchoscope guided lung biopsy, pneumothorax is very less as compared to the CT or ultrasound guided needle biopsy of lung tumor. Open lung biopsy or the video assisted thoracic surgery is another method. However, because of the longer stay in the hospital and the higher morbidity, it is not usually recommended in our day-to-day practice. So tissue sampling is the key to maximize the chance of detecting underlying molecular aberrations. And the pre-procedural discussion at the multidisciplinary tumor board to maximize the yield is very important. And the pathologist should determine the adequacy of the specimen by molecular testing. Whenever possible, priority should be given to those actionable mutations which are more commonly seen, like EGFR mutation and the ALK rearrangement. There are certain challenges like biopsy may not be sufficient for mutational analysis due to the low tumor content and a mixture with non-neoplastic cells. And diagnosis based on morphological criteria may not be possible sometimes, and we need IHC to subtype the NSCLC. Like we may get the result like poorly differentiated malignancy or like that. So how to optimize this? So we need to do maximum with the whatever less tissue we have. So it can be done by proper handling of the biopsy specimen, and it should be placed immediately into the fixative, and it should be avoided with contact on saline soaked gauze piece or mesh pad, and exposure to air should also be minimized to avoid the artifacts. In the examination phase, there should be minimum diagnostic stains and special stains, and unnecessary IHC should not be done. Wherever possible, cocktail antibodies should be used so that we can go ahead with the 2 or 3 IHC staining at a single go. We should be avoiding excessive trimming or leveling, and the IHC should be used very judiciously. If there is a problem in defining whether it's adenocarcinoma or squamous cell carcinoma or any other subtype, for adenocarcinoma, single test like a TTF1 is the best marker, and only one marker can tell you that it is adenocarcinoma. Similarly, for squamous cell carcinoma, P40 is the best marker, and that can tell you that it is a squamous cell carcinoma. So no need to go ahead with a list of IHC profiling to get the exact result, because we need to save the tissue for further analysis for molecular testing. So if we go with the convention for molecular testing, like for ARC rearrangement, we need to do IHC or FISH. For EGFR, we need to do the RT-PCR or any other testing. We need a large volume of tissue, which is not feasible for a lung cancer patient. So the way forward is to go ahead with single test for a single patient. And what is that? That is NGS. So you can see here, there are different methods of testing the molecular aberration like FISH, IHC, RT-PCR. However, the sequencing technology can offer a great or the broad base for detecting the genetic aberrations. The frequently occurring mutations are detected simultaneously, and these NGS-based assays can also detect the chromosomal rearrangement, copy number variations, and insertion, as well as the deletions. So this is the sequencing workflow, the NGS workflow, and NGS can be used it can be done in different platforms. I am not going into the details of this. So why sequencing is important? And it is because it can screen multiple genes in a single run, thus helping conserve precious tissue and save on time. There is a high concordance with the RT-PCR and FISH, and most of the guidelines suggest and recommend the NGS can be done in lung cancer patients. Also, it detects the low frequency mutations or the rare mutations very accurately. So NGS is the way to go ahead. There are instances where we don't have enough tissue for the molecular testing, or the metastasis in a recurrent setting is at such a place where biopsy cannot be obtained, like certain parts of the brain parenchyma or bony metastasis. And maybe patient is not willing for a biopsy, repeat biopsy. So these are the instances where we are not able to procure the tissue for molecular analysis. So in those cases, we have a new tool that is called the liquid biopsy, in which the cell-free DNA that is circulating in the blood of any advanced lung cancer patients, or the circulating tumor DNA, are tested, and this has been validated in various trials, and the diagnostic accuracy of liquid biopsy is approaching 100%. So different techniques can be utilized to test the liquid biopsy, like RT-PCR and NGS. And most of the time now, NGS is the standard way by which liquid biopsy is being tested. So to summarize, optimal tissue sampling and management is the key to identify prognostically important genetic subtypes. And there is a range of molecular methods available to us for genetic testing subtype. However, the NGS is the method to go ahead, and it can detect most of the molecular aberration in a very small tissue specimen as well. So with this, I would like to conclude. Thank you so much for the opportunity.
Thank you, Dr. Abhishek. So I would just sum up in very short few words that yes, definitely lung is a place where biopsy is definitely a difficult scenario. Open biopsy should be avoided as far as possible because it not only adds to morbidity, it also adds to the massive cost in patient. And judicious use of the tissue in terms of putting up ISC markers as well as some other investigation should be done. So thank you, Dr. Abhishek again. So as we are running short, I'll invite Dr. Arunesh to basically take care of the next session, that is panel discussion.
Thank you, Piyush. I'm sharing the slide. Am I visible?
Yes, sir, you are.
Yeah. Okay. So thank you very much, Piyush, and the Paras Cancer team for the invitation. And you know, the panel discussion we are doing this evening is on lung cancer, and particularly specific lung cancer screening that we will be touch base on. Before I start and put the thing in, I would like to invite my panelists today for this evening. Dr. Mangesh Kamath, he is the consultant medical oncologist at Fortis Hospital, Bangalore. Dr. Sanjay Dhawan, he is senior consultant and HOD radiology at Paras Hospital, Gurgaon. Dr. Prakash Sinha, he is consultant pulmonologist at Paras HMRI, Patna. Dr. Piyush Agrawal, who is already there and we are hearing, he is head and neck surgical oncologist. Dr. Kumar Abhishek, he is consultant pulmonologist at Paras, Patna. And Dr. Parminder Bir Singh, who is my co-consultant here at Paras Hospital, Gurgaon. I don't know how many are there, but I believe they are all about to join in. So just to set up the discussion, why we are discussing today is because of this, that you know, the number of cancers and cancer diagnosis is going up with the new advancement, and people also coming forward for the diagnosis. This is the 2020 data from the Globocon. As you can see, this is the number of new diagnoses for 2020, which is about 9 million. This is in females. And as you can see, lung cancer is featured as the third behind breast and colorectal. And if you look at the lung cancer in males, the total number, as you know, will be more because cancer is more common there. So it's around 10 million cases whole world. And here, as you can see, lung and prostate, they are, you know, next to each other, 14.3% and 14.1%. Prostate used to be the commonest cancer, and now both are placed at one place as the most common cancer among the males. So if you look at the Indian data, we like a cancer where we get something like breast. As you can see, you know, majority of your cases are either the local or the loco-regional, where the diagnosis will be very easy, treatment will be very easy, and most of the time you will radically treat it. Head and neck, as you guys were just discussing, you know, majority of your 80% cases are either localized or loco-regional. But the moment you come to lungs, as you can see, we are, you know, around half of the patients will be stage 4 with the distant meds. Loco-regional 37, but most, and this is the Indian data from the National Cancer Registry. Even in the developed world, you know, 50+ % of the patient on the diagnosis are in stage 4. And that is a dire state. You know, this is what we don't want, because once you enter into stage 4, there is very minimal you can do. And that's where the cure rate and medical intervention goes down. So idea will be something where we diagnose, not only diagnose lung cancer, we diagnose it early so that we can radically treat it. This is the survival data for the stages of lung cancer, and this is from UK. As you can see, the 1 year survival, if somebody is diagnosed in stage 1 is 80%, but the moment you stage 4, it comes down to to 20%. So it stays down and it goes down very radically. Indian data, if you look at the, this is the data from AIMS, Dr. Mohan Group, Professor Mohan Group. Stage 4 non-small cell is 68%. Small cell is around 75% extensive stage. So regardless of the cancer histology, the diagnosis, when you diagnose it, the staging is always high. And we need to do something about it. What can be done? So This was the National Lung Screen Trial. We all looked at it with very much hope. And this started in early 2000, which essentially was a screening trial for 55,000 odd high-risk volunteers between 55 and 74 years. They all had a minimum 30 pack years, or they were current smokers or having quit their smoking in the last 15 years. They were randomized either to have a 3 low-dose CT versus a chest X-ray PAView, and were followed up for 6.5 years. And it was found that in the CT arm, there was a 20% fewer death as compared to the chest X-ray. And if you look at the number you screened to prevent one death, is 322 patients screened to prevent one lung cancer death prevention. If you consider and compare this to the breast cancer, if you do a mammography, you do 519 mammography to prevent one cancer death. And you compare this, you do 320 lung cancer screening to prevent one lung cancer death. So it was like a very good intervention in not only diagnosing, but also preventing the mortality. 6.7% in the CT arm. And this is the graph, as you can nicely see, low-dose CT scan on the top, chest radiography. There's a significant number of diagnoses you are doing, and also you are reducing the death. So that was from NLST, National Lung Cancer. Same thing was followed up in the Scandinavian country. And you can see in the Nelson trial, again, 15,000 odd people, high risk population. And here the CT scan versus no screening at all was done at 1, 3, and 5 years. And once again, the mortality was significantly down in the CT arm at 10 years. So not only you are reducing the mortality, you are taking it up over 10 years. So this is a significant, again, intervention in not only diagnosing, but also reducing the mortality. Now, with this in mind, my first question will be to Dr. Dhawan, who is our radiologist at Paras Hospital, that what is low-dose CT cancer and how is it different to conventional CT? And the one thing when we were discussing, when we were start at Paras, was how to get people on board. That because there are certain radiation hazard, and people always think that it's get a CT. So how can we motivate people? How can we improvise by saying which way we should present for them to come in a larger number? Because our area also is a high smoker area. So over to you, sir.
Thank you, Dr. Runesh, and thank you, Paras Cancer Center, for the kind invitation. So you have set up the stage very nicely, Dr. Runesh. The NLST is the kind of study which has guided low-dose CT, and now it is come into purview. There is no doubt that there is significant decrease in mortality if you pick up the lung cancer early. Basically, you get an opportunity to treat it effectively and soon enough. So the question is, who should be screened? The NLST was, and the subsequent studies like Nelson were also restricted only to the high-risk groups, population which is a smoker 55-year onwards and 25 years history of smoking. They were selected for this screening. Low-dose CT is effective. Let me put the radiation issues to rest. We use lower kVp and lower tube currents to generate the CT scan. It is poor on resolution than the normal CT scan. But if I were to give you an idea of radiation dose, a normal CT chest gives exposure of 7 millisieverts, whereas a low dose CT would be less than 2 millisieverts. So the difference is significant. That is one. Second, one should also remember that because we are compromising on resolution, so it is possible in some patients due to body habitus, we had to upswing that. But then again, that is in the interest that study be accurate, which is the primary aim, to pick up the lesions. And so we are picking up now solid lesions on a low dose CT. We are picking up sub-solid lesions. Sub-solid lesions could be pure ground glass or mixed ground glass and solid. This is how we characterize the nodules. But what is important now is that one has to understand just doing the low dose CT is not enough. There has to be a guided management program for the nodule which you have picked up. So either it has to be a follow-up, it has to be comparison, or it has to be a biopsy or a PET scan. So all this is very important. I mean, you have to keep the patient engaged. It is not like you get a test done and then you go back home. And the follow-up is very important. So one thing which I would like to probably tell you is that NLST showed around 90% false positives to start with, because the nodule was picked, it was a first scan, and the most compelling evidence of benignity even today is lack of growth of the nodule over a period of time. So for which a follow-up scan has to be done, be it at 6 months, 1 year or 2 years. Ground glass opacities, which are kind of precursors to the adenocarcinoma, they are prone to develop very slowly, and a follow-up of 5 years is required. So that is one difference between a solid nodule and a subsolid nodule. And I think last I want to highlight a couple of things. What are the barriers to screening? We know about the NLST. NLST concluded in 2009. It's been 12 years since then. But this kind of low-dose CT screening has really not come into practice, at least in India. The reason is, one is the financial cost. CT scan is an expensive test, and because it is not like an X-ray, the cost is a factor. Second, radiation issues kind of put the population behind. But as I said, radiation is really not the issue. The people have to be motivated. And third is the false positives. So that is why, I personally feel the way forward is that we have a program of basically cessation of smoking cessation. Patients are enrolled into those clinics on grounds of positive health. Out of those who enroll, motivated individuals who fall into the criteria of screening are kind of encouraged to go this low dose CT. And then each patient, each nodule is a patient. So each nodule or each lesion which is detected on the low dose CT is followed as per the protocol. So we have a very effective system these days, lung RADS, in which reporting is very specific, and the categorization also guides the management that specifically.
Yes.
So I think that would be all. And if there is anything else I could answer. Thank you.
Thank you. Thank you, sir. That was very rightly. So as Dr. Dhawan just said, not all lung spots which we diagnose on the low dose CT are cancers. And that led to a barrage of workload, because now that you have screened somebody, you have found a spot. And if you look at the low dose CT in National Lung Screen Trial, 96% of LDCT and 94% of the X-ray were false positive. So they were showing a spot, but they were not cancer on the subsequent further investigation. Benign lymph nodes and granuloma was the commonest finding. So I worked in UK. We had this UK lung cancer screening, and we were swamped with this report. So we had a special clinic after the patient comes with a national lung screen. So we need to have a plan, as Dr. Dhawan just said, that what we are going to do after we have scanned and we have found something. So the next question is from Dr. Prakash Kumar. Is he there? I can't see him on the picture. That how, Dr. Prakash, how do we do what we have found a solitary pulmonary nodule, and how do you investigate? How do you interrogate it further? Is Dr. Prakash is there on the? No. Okay. Dr. Abhishek? Dr. Abhishek, pulmonologist from Patna?
I think you'll have to answer, sir.
Okay. So, right. So I have a algorithm there. So solitary pulmonary nodule, what are they? So normally you characterize, these are the list, as you can see. Most of the time, only tiny of this is neoplastic, which is around 2 to 3%. So 96%, as you just said, in national lung screen was benign. So they can be either malignant. Of course, we want to look forward and look for it. There are significant chunk of it are benign. They could be pulmonary hematoma, they could be chondroma, inflammatory. In India, for instance, I have written TB in bold letters here. TB is rampant, in Indian subcontinent. Sometimes you can get, having a post-TB nodules, your calcified nodules. You can have a healed tubercular lung abscesses, which behave like a mass. You can have a pseudotumor, You can have congenital abnormality like AV malformation. You can have pulmonary infarct, OSP. So it's like a barrage of things that comes out. And once we have diagnosed, we have to have a program where we deal with all these things to have this low dose CT working, because these patients are anxious. We have just screened them and we have told them that, you know, you have got a shadow. It's not a cancer, then what it is. So these sort of things. Normally in BTS programs, we have somebody, I'm just giving you a schema here because my panelists are here are not there. So somebody, you have found a solid non-calcified nodules on CT scan. You basically look for it. If there are features of benign disease and less than 5 millimeter, you discharge them. You don't take it any further. If the patient has a previous imaging, and if the previous imaging, the nodules are less than 8 millimeter, you do a CT surveillance, which is coming on the next slide. If these lesions are less than 8 millimeters, or more than 8 millimeters, then you go for a PET scan. And that's where the role of PET scan comes. So you never do a PET scan if the lesion is less than 8 millimeters. Once you have done a PET scan, then you apply a Herder model or separate. There are different models in different studies. You can apply one of them, which essentially risk stratify that nodule for you on the PET scan. On the Herder model, if there is a less than 10% of lung malignancy shown, then you put them on a CT surveillance pathway. If it is 10 to 70%, then you consider CT guided biopsy and whatever mode you think will give you a tissue. On the Herder model, if it says that there is a more than 70% risk of malignancy on the risk stratification, it says there is no point doing a biopsy of a 1 centimeter nodule, where the chances are, even if it says it is negative, you're not going to take that on a face value, and you rather excise it. You go for a surgery directly. So these are the way we can, just on the basis of PET, you can stratify them into 3 arms, where less than 10, you do a CT surveillance, 10 to 70, you want to do image biopsy first, and then proceed further. More than 70, you can go for directly surgery. You don't want to biopsy it. Regarding the CT, if somebody has got 5 to 6 millimeter, and you do a CT at the end of 1 year. If somebody has got, if it is more than 8 millimeter, you do a CT from baseline at 3 months. And if they are growing, you can assess that on a CT scan. Then you do accordingly. If they have grown further, you get a CT scan, and then you do for a sampling and the biopsy accordingly. Now, do we have any of them? I mean, Dr. Abhishek, are you there? That will be the one question. That we are a high incidence TB country. How often do you come across the TB as an etiology for solitary pulmonary nodule? And the other things like a non-tubercular mycobacteria and fungal component. And how do you follow up? I can see Dr. Prakash. Dr. Prakash is here now. Dr. Prakash, can you unmute yourself? Dr. Prakash Sinha. Dr. Prakash Sinha, I can see you there on the screen. Can you unmute yourself?
Yeah. Good evening, everybody. I'm Dr. Prakash Sinha from Patna Paras HMRI Hospital.
Dr. Prakash, can you take this question now, please? I mean, the question is more about the TB and SPNs.
Yes. Very often, sir, I used to see here tuberculosis patient. Patient comes with from periphery or from other centers, or on ATT being started there with minimal investigations. They only outside the doctors or whoever the physicians, they only see the X-ray and go for this primary examination of sputum for AFB, whatever the gene expert, and without querying on the gene expert report whether it is negative. If it is negative, then seeing the chest X-ray and some findings of bronchiectasis or whatever the localized lesion or the opacity of the chest CT scan, they usually start the ATT empirically, and when the patient deteriorates or when he gets some liver pathology or some liver parameter derange, then they used to come to us, and then we go for this for further workup, whether tuberculosis or whether it's some other etiology. Then we go for bronchoscopy and whatever. And very often I used to see at least 4 to 5 patients coming for the centers to us with the diagnosis of tuberculosis, and just we go for all the parameters. We go for bronchoscopy and whatever the methods we have here. and 2 to 3 patients in 10 days. We are getting for just for malignancy or whatever the lung cancer patients.
Yeah, very right, very right. I think it's all about, you know, the early. So once they have done the CT, I think they should be looked for all these etiologies first, because some of them you have started this and they come out to be something else. So it's very important, the treatment as well as how you follow them up. So that's great, Dr. Prakash. I mean, next I move on to to Dr. Piyush. Now that we are going to screen, or we are screening patients, Piyush, how does the low dose CT scan changes the lung surgery landscape? And how do you see the role of minimally invasive surgery in early stage lung cancer?
Sir, it has immensely changed this landscape, basically. So few of the studies have shown that 85% of the stage 1 cancers are detected when we do basically low-dose CT scan, low-dose CT screening. So first and foremost, that one is that we will be detecting cancers at a very early stage. Second is that the studies like MILD have shown that there is a 39% reduction in mortality over 10 years if we basically follow up for that long. So first thing, that we will be able to detect the cancer at a very early stage where it is entirely operable and treatable. Plus, we will be able to use minimally invasive surgery. When the cancer is in an early stage, is a small tumor, we can use minimally invasive surgery, which is definitely a lot advantage over an open surgery because of the lesser amount of morbidity, the less amount of pain, very early recuperant of the patient. Patient starts moving. So many things improve when we basically are able to do a minimally invasive surgery. So definitely, low dose CT has changed the scenario. Plus, India as such, one is smoking, definitely it is there. Second, the rising levels of pollution in metropolitan increasing the lung cancer incidence. Plus,
Dr. Arunesh, Dr. Piyush, I'm sorry to interrupt, but Dr. Arunesh, you're left with 4 minutes for your panel.
Yeah.
And we have one question in the chat box from the delegates.
Okay.
Plus the smoking increase in females, it has definitely increased the lung cancer scenario in India. Low-dose CT definitely helps.
Right. Okay. So I don't think, do we have an oncology presentation? Dr. Mangesh, you want to take?
No, I don't think so.
No? Okay. So Dr. Parminder, are you there? It's about getting that dual pathology. Dr. Parminder?
Sir, I'm there.
Hello.
Good evening.
Good evening,
Yeah,
Parminder.
he's there. He's there.
Yeah. So your question was, Parminder, how often do we see the combined pathology? We do come across having a cancer with TB, cancer with ILD. How should be the management strategy? How differently should we manage it?
So I will first of all thanks the organizing committee for inviting me. Good evening, sir. So we very often see patients with dual pathology, especially TB and cancer lung. We do often come to see these patients very often. I would like to say that in various case series, around 4 to 10% of the patients initially presenting with cancer lung are also found to have coexisting tuberculosis. The presenting symptoms of both the diseases are similar, such as fever, cough, loss of weight, decreased appetite. And if the radiology favors cancer lung, we tend to miss tuberculosis in this patient. So if we are going ahead with a diagnostic test to diagnose cancer lung, and we should not miss the microbiological examination of AFB stain, AFB culture, gene expert. These are very often missed. If these are not done, then we will not get to know whether patient has coexisting tuberculosis or not, and which has a very important role in the further prognosis and management strategy, such as if patient has a dual pathology, then we need to give first anti-tubercular treatment for at least 2 to 4 weeks before starting any cancer-directed therapy. Otherwise, patients are at risk of developing disseminated tuberculosis.
Very right. I think that's the idea, that whenever you think, Dr. Parminder was saying that whenever you take a sample, always remember one sample has to be in saline, regardless of where you took, because we all know Piyush has recently operated on somebody with a granuloma, ultimately found to have a lymphoma. So, you know, those granulomas are very, isolation granuloma is not something we should carry on. So that's great, Dr. Parminder. And this is the low dose CT pathway, which I will keep the thing on while we take questions. Dr. Aditi, where can we get questions? Do you have a question?
So the question is in the chat box. The question is, what should be the screening criteria for lung cancer? Should it be age-based or the number of years of smoking?
So it is both. I have just left it. That's why I have kept this thing on. So this is, I have taken, this was the NHS pathway. We don't have to do that, but it works very well. So basically 50 to 75, I mean, everywhere this age group we write, we either do a current smoker of 30 pack years, or they have stopped smoking within the 15 years. So somebody has smoked even, you know, whatever, less than 15 years, 15 years has quit smoking and is between 55 to 75 bracket, should be invited. I think Dr. Dhawan was very, he raised a very pertinent point that just doing a CT is not enough. We need to get it in our pathway. So in this pathway, as you are rightly saying, not only we are checking them for cancer, we are also checking them for COPD. We are checking them and we are supporting them with a pathway where they are not just left with a CT scan showing a 80 millimeter nodule or 6 millimeter nodule, and we are not sure what we are going to do next. So I think this should be a pathway driven, and the patient in this age group should be invited for the CT.
Just one point can I make, Dr. Runesh?
Yes, please. Yeah.
Yeah, the only thing is low dose CT is just a screening tool. I mean, that should be very loud and clear.
Yes.
If suppose there is already a nodule or a lesion, then we don't ask for a low dose CT. Then we ask a full dose contrast enhanced CT. So that is something I thought I'll just make it clear.
Yeah. Yeah. Next question, Dr. Aditi, you have.
So that will be it. We just had one question.
One question. Okay. Yeah. So I think this is what I think, you know, depending on 5 millimeter concept, we can keep less than 5, you reassure. Between 5 to 8, you have got a various way of doing first 3 months CT followed by 12 months CT, and we can formalize it. At the same time, all the smokers are provided the, you know, smoking cessation pathway. There was a very good session before. And also if they have got a COPD, we diagnose COPD. So idea is not only we pick up the, create the, and diagnose the cancer early, we also treat the comorbidities around. So I think we have done on time, Dr. Aditi, is that right? So I want to thank all my panelists. I think Dr. Parminder came up, and Dr. Prakash and Dr. Dhawan, which we were both waiting for and listening some ENT discussion nice and early. I mean, I got some, you know, very good vocal cord thing today. So it's great. So I think that will be all from our end. Over to you, Dr. Piyush.
Thank you.
Thank you, sir.
Thank you, sir.
So because we are running short of time, so I'll directly go to Dr. Vibhor and hand over the proceedings to him for the next session. Dr. Vibhor, please.
Hello.
You have to unmute yourself.
Dr. Aditi, I am there in the picture, and let me initiate if you wish, or shall I give my comments a little later, or?
Sir, Dr. Vibhor will just invite you, then you can proceed.
Okay.
Good evening,
ahead,
everyone.
Dr. Vibhor.
As we move to the last session of today in Hall D, I would like to call upon Dr. A.K. Israni, sir, to chair this session. Dr. A.K. Israni is a very senior practitioner. He is the Honorary Joint Secretary of IMA headquarters at national level. And in the past, he has held several administrative positions through his illustrious career spanning over 3 decades. He has been awarded with several prestigious awards, and recently he got the Medical Ratan Award. I would now like to invite Dr. A.K. Israni to chair this session.
Thank you, Dr. Vibhor, and I have brought greetings from Indian Medical Association headquarters. You have narrated about my few involvements, and I'm thankful for you. Thankful to you, and my compliments to Dr. Rangarao, Dr. Aditi, to you, all the speakers, as well as the panelists. And as Dr. Vibhor said it, first topic would be Dr. Vibhor Sharma would be speaking. He is senior consultant and hematologist, onco-medical specialist, as well as he is doing bone marrow transplant also. He is from Paris, Gurgaon. Approach to pancytopenia, he'll be talking, and second speaker would be Dr. Avinash Kumar Singh. He would be talking how to manage patients with bleeding diastasis. And third would be, moderator would be Dr. Brigadier Ajay Sharma. And he'll be taking forward the panel discussion. He's Director Hematology and Bone Marrow Transplant. And Dr. Avinash Kumar Singh is HOD, Senior Consultant Hematology, Hemato-Onco and Bone Marrow Transplants. He's from Paras Hospital, HMRI, Patna. So over to Dr. Vibor for deliberation of pancytopenia. How it happens, actually, I'm a physician, as you said it. Causation, I would be interested that all the audience would be interested into listening to you to rule out malignancy part, if at all. And is it idiopathic most of the times, or it is malignancy? What would be the clinical scenario? Over to you, Dr. Vibor.
Thank you so much.
Dr. Vibor, you can start now.
Is the screen visible?
No, your screen is not visible.
Okay, can I request the backend team to share the presentation then?
Aram, please share Dr. Vibor's presentation. Aram, can we have Dr. Vibor's presentation, please?
Yes, ma'am. We will share. We will share shortly.
And we can start the timer once Dr. Vibor starts.
Yeah. So good evening, everyone. So the topic allotted to me today is approach to pancytopenia. Irrespective of whichever specialty we are practicing, we encounter this condition very often, whether we are internal medicine or an intensivist or a pediatrician or any other specialty. So this is a very important topic. So coming to the definition, pancytopenia is defined as a decrease in all the three cell lines of blood, namely the RBCs, leukocytes, and platelets. In terms of numbers, it is defined as HB less than 9 gram %, WBC count of less than 4,000, and platelets of less than 1 lakh. This is one of the most common causes of referrals to hematologists. Next slide, please. So the presenting symptoms are attributable to anemia, leukopenia, or thrombocytopenia, and there could be fatigue, breathlessness, or cardiac symptoms, easy susceptibility to infections, and mucocutaneous bleeds and easy bruising. Next slide, please. Next slide. So coming to the etiopathogenesis, as I said earlier, pancytopenia is not a disease in itself. It is just a blood picture which has been brought up as a result of some or the other underlying pathology. The pathology could be either a result of decreased production in the bone marrow or increased peripheral destruction, or both of the above. Next slide, please. So coming to the specific causes of pancytopenia, we broadly divide them into conditions with a hypocellular marrow and conditions with a cellular marrow. When we talk of conditions with a hypocellular marrow, they are mostly hematological conditions like acquired or congenital aplastic anemia, some varieties of MDS, AML, ALL, and bone marrow lymphoma. When we talk about conditions of pancytopenia with the cellular marrow, a lot of them are related to systemic diseases, not because of any underlying hematological problem like nutritional deficiencies of vitamin B12, folate, and copper, hypersplenism, alcoholism, a lot of infections, including sepsis, enteric fever, miliary Cox, variety of viral infections like HIV, hepatitis A, B, and C, EBV, CMV, malaria, leishmaniasis, and autoimmune conditions like SLE and sarcoidosis. Many of these conditions are also because of primary marrow problems, and they could include myelodysplastic syndrome, PNH, myelofibrosis, subleukemic leukemia, bone marrow lymphoma, and hairy cell leukemia. Next slide, please. Then there are a multitude of drugs causing this condition, and they include both chemotherapy agents and others like NSAIDs, antithyroid drugs, anti-epileptics, chloramphenicol, azathioprine, and sulfonamides. Next slide. So there have been 2 large studies in India and looking at the causes of pancytopenia, one from the northern part of our country and another one from the southern part of our country. And in adults, both of these studies found that megaloblastic anemia and aplastic anemia are the most common causes of pancytopenia that are seen in adults in India. Next slide. Next comes the approach. When we get a referral for a pancytopenia, how do we approach the patient? As in any other medical specialty, we have to go ahead with a meticulous history taking and a detailed physical examination. The history should focus not only on the symptoms alluded to previously, but also a detailed dietary history is very important, history of alcohol intake, family history of hematological problems, any history of suggestive of liver disease, autoimmune phenomena, recurrent oral ulcers, weight loss, anorexia, or B symptoms should be taken. Looking at the coming to examination, we have to look for the common signs like pallor, icterus, any petechiae, hepatosplenomegaly, and other features of specific diseases like malar rash, lymphadenopathy, stomatitis. When we talk about the lab evaluation, the 2 most important investigations to be done are peripheral smear and reticulocyte count. And it is important to highlight that both of these should ideally be done before the start of therapy and definitely before we give any blood product infusion, because after that the results may alter. Depending on these reports, we go ahead with further investigations including LFT, ANA, viral markers, B12, ferritin levels, folate levels. So bone marrow examination is required in most of the cases of pancytopenia, in almost all the cases unless an obvious cause is found out, for example, a CLD or a megaloblastic anemia. Next slide. The importance of reticulocyte count is cannot be ignored. The normal reticulocyte count is 1 to 2%. This should be done before starting therapy, and this is a very important investigation which distinguishes hypoproliferative from hyperproliferative states. Next slide. Then there are specific evaluations depending on which disease the initial reports have pointed out to. I would not like to go into the details of these specific tests. Next slide. Now I would just like to walk you through 4 cases that I selected. This is an 18-year-old girl who presented with easy fatigability and yellowish discoloration of eyes for 1 month. She had pancytopenia, peripheral smear did not reveal any atypical cells. Her MCV was high, LDH was elevated, and total bilirubin was 2.5. So far, it is looking like a hemolytic anemia, but when we did the retic count, it was found to be 1.3%, which is quite low for this level of anemia. B12 and folate levels were low, so this turned out to be a case of megaloblastic anemia. Next slide. Then there's a 23-year-old male who presented with easy fatigability and generalized body ache for 1 month with a pancytopenia. He had been treated outside with blood products, vitamin B12 and folate supplements without any improvement. The retic count was normal, LDH, LFT, B12, folate levels were normal. Upon the bone marrow examination, the cellularity was 20%, suggestive of aplastic anemia. There were no malignant cells and no increase in fibrosis. PNH clone was negative and chromosome breakage studies were normal. So this came out to be a case of aplastic anemia. Next slide. Another case is a 72-year-old male presenting with easy fatigability and B symptoms with pancytopenia. The bone marrow was hypercellular, 60% cellularity with 15% blasts, and dysplasia affecting 2 lineages. On the FISH test, deletion 7q was detected. This was a case of myelodysplastic syndrome. Next slide. This is a 16-year-old girl who presented with fever, easy fatigability, and heavy menses. A very short history of 10 days with pancytopenia. Examination revealed gum hypertrophy and 3 centimeters splenomegaly. Bone marrow was packed with blasts with air drops positive. Flow cytometry was suggestive of a female. Next slide. So to conclude, the common causes of pancytopenia among children are aplastic anemia and leukemia, and in adults they are megaloblastic anemia and aplastic anemia. Early identification of these conditions is very important. This point needs to be stressed because if you are dealing with a aplastic anemia or a MDS or an acute leukemia, even one infection can have a lot of impact on the prognosis as well as treatment. These patients, once they get infected, may become treatment ineligible. So if we have a suspicion of such cases, they should be referred to appropriate centers. And next slide. Thank you very much for your patient hearing.
Thank you, Dr. Vibor, for wonderful deliberation. I would be asking only one question. Can you deliberate upon the aplastic and the difference between aplastic anemia and megaloblastic? In nutshell, can one, two, 3 points, if you tell us, for physicians' benefit? And very rightly, you have pointed out reticulocyte count again is an important feature which you have to incorporate. Can you just give me the difference how the patient will present with the aplastic anemia or megaloblastic anemia?
So that's a very important question, and that's a very practical question that we see. In megaloblastic anemia, we usually have got something on the history and in terms of B12 folate tests or homocysteine levels, which are pointing out to an obvious nutritional deficiency. In addition, the patient may be deficient in iron, which can be found out by having low ferritin levels. The bone marrow examination may not show hypoplasia in case of megaloblastic anemia. It will be a cellular marrow, whereas in case of aplastic anemia, it is typically a hypocellular marrow with cellularity less than 25%, and then there are various grades of aplastic anemia: severe aplastic, non-severe aplastic, and very severe aplastic anemia, depending on the levels of reticulocyte count and neutrophil count that we are seeing.
Okay. Thank you, Dr. Vibor. We'll take question from chat box as Dr. Aditi earlier said it. And can I invite Dr. Avinash Kumar Singh? I've already given his brief achievements. Over to Dr. Avinash. He would be talking on to how to manage patient with bleeding diathesis. I would be asking him about how to rule out disseminated intravascular coagulations and coagulopathies and other features related to hematological malignancy, may it be bone marrow infiltration or any other feature. And could it be aplastic anemia also? How to approach the related issues and management? And what would be the message for physician? Will there be in management monoclonal antibodies or steroids? Over to you, Dr. Avinash Singh. Your time.
Yes. So
it is 7 minutes.
So am I?
Yes. Voice is breaking.
Hello. Am I audible, sir?
Yes. Yes. Go ahead, please.
Okay. So.
Hello. Hello.
Go ahead, please.
Hello.
Yes, we are able to hear you. Yes.
Thank you, sir. So,
Dr. Avinash, are you able to hear us?
Yes, sir. Yes, sir. Yes, sir. So, thank you, sir, for kind introduction, and I would like to thank organizers for giving me opportunity to speak today. My topic is approach to management of a patient with bleeding diathesis, and I would like to say management of all bleeding diathesis in 7 to 10 minutes time. I am going to present is a patient in short. Slide is not moving. Okay. So bleeding diathesis is inherited or acquired disorders which affect primary or secondary hemostasis. And we all know that normal hemostasis has a role in controlling bleeding. So they keep the blood in fluid state, and the components of normal hemostasis are blood vessels, platelets, plasma coagulation factors, and fibrinolytic system. So primary hemostasis are mainly platelet and vessel wall mediated. Whenever there is problem in primary hemostasis, the bleeding occurs within seconds of injury. The primary hemostasis leads to formation of platelet plugs, while secondary hemostatic system are coagulation factors mediated, And whenever there is problem in clotting factors or coagulation factors, they take several minutes for completion. They form. So, what are the occasions or indications or condition when patients are referred to a hematologist for suspecting bleeding diathesis? When a patient or referring physician suspects that a patient can have bleeding diathesis, when there is family history of bleeding diathesis, then the family members referred to a when during checkup for a job or health checkup or during pre-op evaluation, it is found that there is some abnormal lab, and whenever there is unexplained bleeding, like even without trauma or delivery, if it is unexplained, then they are referred for evaluation. So it is very important that any patient is having bleeding diathesis, we should take a very good history, bleeding history. And why? Because there are different symptoms which can vary in different disorders. Their diagnostic value can differ. Always we should assess the extent of hemorrhage against the background of any trauma or provocation, whether bleeding has occurred without trauma or with minimal trauma or a significant trauma is important to understand. Whenever we take history, it is important to confirm the subjective information that we gather with objective confirmation, objective evidence. Some in clinical self-administered questionnaire, but it is not substitute for a good dialogue between a physician and the patient. It is important to note all the medication that patient is nutrition history is important for vitamin K deficiency. Whenever bleeding is isolated to a single organ or system, it is very likely that they will have local problem rather than a bleeding diathesis. May blood vessel disorder. So sometimes in telescopic view, we all start doing starting from basic test to NGS, and we don't think that bleeding can occur because of blood vessel disorder. So it's important. And history should include information on diseases and organs like liver disease can lead to bleeding, kidney disease can lead to bleeding manifestations or bleeding diathesis by various mechanisms. So primary hemostatic problem will present with mucocutaneous bleeding, and the secondary hemostatic problem will have deep joint bleeding or skin hematoma. These are some causes of bleeding diathesis, like acquired. They can affect platelets, liver disease, renal failure, vitamin K deficiency, or other acquired inhibitors, DIC drugs, or vascular. These causes are acquired causes of bleeding diathesis. Then inherited, again, they can involve clotting factors, platelet disorders, fibrinolytic disorders, vascular, then connective tissue disorders like Ehlers-Danlos syndrome, they can be inherited. Then drugs like anticoagulants, they are notorious for causing bleeding. Antiplatelets, including NSAID, glucocorticoids, antibiotics, SSRIs, alcohol, vitamin E, and drugs, or even food like garlic and ginkgo biloba can lead to manifestation by platelet dysfunction. There are some clinical manifestations which can hint that patient can have some characteristic or some specific hemostatic disorders like mucocutaneous bleeding. They can be seen in mainly platelet-related dysfunction or von Willebrand disease. Cephalhematoma in newborns, hemarthrosis, hematuria, they can be seen in clotting factor abnormality. Injury-related bleeding and mild spontaneous bleeding can be seen in mild factor deficiencies. Bleeding from a stump of umbilical cord and habitual abortions can be seen in fibrinogen disorders or factor 13 deficiency. Impaired wound healing can be seen in factor 13 deficiency. Facial purpura in newborns can be seen in granulomatosis, thrombocythemia, or severe thrombocytopenia. And recurrent severe epistaxis and chronic IDA can be seen in hereditary hemorrhagic telangiectasia. So after history, we should always concentrate on skin examination to look for petechiae, purpura, or ecchymosis. General and systemic examination should be directed towards whatever history we got. Bleeding assessment tools are, BAT scores are very good tool to look for. If score is less, it is unlikely that patient will have bleeding diathesis. If it is more, it is more likely is having bleeding diathesis, and we should investigate them properly. Lab investigations, the screening coaglogram, the basic investigations which are important is CBC, peripheral blood smear, bleeding time, prothrombin time, APTT, and platelet count. And along with history and these physical examination, lab investigation, we should all correlate every findings, and then we should come to a final diagnosis. Some small clues like perifollicular hemorrhage can be seen in vitamin C. Some petechiae or wet purpura can be seen in thrombocytopenic disorders. These are coagulation cascade, and this is extrinsic pathway tissue factor. and this is monitored by prothrombin time. These are intrinsic pathway. These are monitored by APTT, and these are common pathway. Whenever there is problem with common pathway or combined deficiency of factors, it can lead to prolongation of PT and APTT. So another fibrinolytic pathway is there, like plasminogen is converted to plasmin which leads to degradation of fibrin to FTP and D dimers. So if there is any problem in this pathway, there can be again excessive bleeding. So how to interpret the lab results that you get? So PT, if it is prolonged, isolated PT prolongation with normal APTT, causes can be factor 7 deficiency, vitamin K, liver disease, warfarin, DIC. Again, if isolated APTT is prolonged, it is commonly seen in factor deficiency like 8, 9 or 11 deficiency, von Willebrand disease, and drugs like anticoagulants can lead to APTT prolongation. And some inhibitors like lupus anticoagulants can also lead to isolated prolongation of APTT. When both PT and APTT are prolonged, it can be because of common factor deficiency, combined factor deficiency, and disease like liver disease, DIC, severe vitamin K deficiency, or anticoagulation can lead to both PT and APTT prolonged. There are occasions when APTT and platelets are normal, but still patient is having bleeding. So we should see bleeding time. If it is normal, it can be factor 13 deficiency or alpha 2 antiplasmin deficiency, dysfibrinogenemia or HHT. If BT is prolonged, then we should see the ristostatin cofactor. If it is less, it can be VWD. If it is normal, see clot retraction. If it is abnormal, it can be GT. If it is normal, it can be hereditary and acquired platelet disorders. So briefly about management, so always avoid trauma in a patient bleeding diathesis, avoid IM injections and avoid NSAID. The drug that we use in problems in a patient of bleeding diathesis is glycemic acid, which is an antifibrinolytic agent, and the antifibrinolytic agent, and commonly the drug IV we use 10 to 15 milligram per kilogram 6 to 8 hourly, and oral dose is 25 milligram per kilogram 6 to 8 hourly. Then fresh frozen plasma is another blood component that we commonly use to control bleeding for patients with, again, sir has asked about DIC, so one indication where we use FFP, or even in some patients with clotting factor deficiency, when exact clotting factors are not affordable or not available, we have to use FFP. So dose is 10 to 15 ml per kilogram, over 1 hour. Indications of FFP.
Dr. Avinash, I'm sorry to interrupt, but your time is up. Can you please wrap up quickly?
Yes. So other agents which we use is cryoprecipitate, then activated prothrombin complex concentrate, mainly in hemophilia with inhibitors. Novosen 7 is activated. Again, it is indicated for hemophilia with inhibitors. Hemophilia is a multidisciplinary team approach to be applied for management of hemophilia patients. Price therapy, factor replacement is important, again with physiotherapy, psychological counseling. So these are all about price. Then management of minor bleeding is directed towards the site of bleeding. Desmopressin is another agent which we use for hemophilia A and VWF. In hemophilia, on-demand prophylaxis are the two types of management that we do with factor replacement. These are World Federation of Hemophilia. Depending upon the site of bleeding, we have
Dr.
to.
Avinash, please wind up as time is constrained.
Yes, sir. These are about ITP, adults and pediatric ITP. In cases of significant bleeding, only we should start treatment, or if platelets are less than 30,000. So to conclude, workup of a bleeding patient is challenging but interesting. It needs patience and time from physician as well as patient. Systematic approach, which includes history, physical examination, and lab investigation, can provide correct diagnosis. Management is to prevent bleeding or to control in case of bleeders. Avoidance of NSAID is important to communicate, and management should be directed to the exact cause of bleeding. Thank you.
Thank you, Dr. Avinash, for wonderful deliberation. Long topic covered in short time, narrated numerous causes and liver disorders and vitamin K deficiency, fibrinogen related issues. And if at all bleeding occurs, the intracranial hemorrhages in physician scenario and cardiology scenario, we have been seeing people taking dual antiplatelets. What precaution should be taken? They have been taking dual antiplatelets. What do you give your opinion in a nutshell in just 1 minute time?
Yes, sir. So patients, yes. So cardiological patients who are on double antiplatelet, they have high risk of having bleeding, and they are yes, very emergency where we have to transfuse platelets. First, we have to stop the antiplatelet. And unfortunately, even the platelet transfusion doesn't help much, because the circulating antiplatelets, whatever platelet we will transfuse, they will make it dysfunctional. So we have to manage with stopping platelet transfusion, and that is again antifibrinolytic agent we can use, like tranexamic acid or epsilon aminocatinoic acid.
Okay. Thank you, Dr. Avinash. Now over to Dr. Brigadier Ajay Sharma. He is from Panchkula. He'll be taking over for panel discussion, and he's Director Hematology from and doing bone marrow transplant. He has, as I said it, is from Panchkula. And panelist would be Dr. Sumit Jain from Panchkula, Dr. Pawan Goyal from Rewari, Dr. Mukesh Kumar from Patna, Dr. Rajesh Kumar for Gurgaon. Over to Dr. Brigadier Ajay Sharma. Is he here?
Yeah,
Dr.
I'm very
Rajesh
much
Sharma?
here. Thanks, Dr. Sani. Thank you very much for giving me this opportunity to share with you the clinical aspects of pancytopenia and bleeding disorders at the fag end of this presentation. Can I have the slide projected here? And meanwhile, we are getting the slides projected. So we have actually had 2 sessions on pancytopenia and bleeding disorders, and they have been actually very extensively covered in a very short span of time. And now in 20 minutes, we will not be able to do justice to do both these topics. So we'll just have one topic discussion here, and we will just mainly confine to the bleeding disorders. And just starting with this topic, as it has been highlighted by both the speakers, that the hemostasis is a property of the blood. Our blood actually is meant to clot, and whenever there is an abnormality, there is a bleeding. So this has been what is have been taught to us conventionally from ages, that the cascade theory of the coagulation, but now it has been challenged with the newer concept. Can I have the next slide, please? In which we have the physiological pathway of the coagulation. That is what it is, where mainly the interaction of the tissue factor with the factor 7A initiates the process of coagulation, and there is a fibrin deposition that takes care of the bleeding that is occurring in the patient. Next slide, please. And as I mentioned, the result of failure of the body's hemostasis results into the bleeding. Next slide, please. Bleeding, as Dr. Azani was just mentioning, is a major complication and major presentation in an acute setting in an ICU, where a large number of patients present with bleeding. The bleeding can be systemic bleeding in any organ of the body, or it can be CNS bleeding, or it can be coagulopathy of various reasons. Next slide, please. So it has got a major impact upon the bleeding. Now, I will request one of the panelists, Dr. Sumit Jain. Can you just tell us about the some of the causes of the uncontrolled bleeding in an emergency room? Because that is where we get all these patients, and they come to us in the emergency. Dr. Sumit Jain. Yes.
Hi,
Yeah.
sir. Thank you for the invitation, sir. So the most commonly what we see with that, like emergency, either they're the trauma patients with the crush injuries, and sometimes like patients, which I already said, the cardiac patients which are already on double antiplatelet drugs. Most commonly, just patient present with hematemesis, melena, and alcohol. We are in the Punjab, and it is a state where alcohol consumption is very high, and the liver diseases are very high. So we are again having patients with hematemesis, melena. It's very quite often where we see in the emergencies, and in female patients, the menorrhagia problem is very common, along with some thyroid disorders.
All right, next slide, please. So, next slide, yes. So, in an emergency room, the most commonest cause of bleeding, a patient coming to us with bleeding, the trauma, and sometimes it can be post-surgical when a patient has undergone a recent surgery. Then we have the bleeding because of the low platelet count. That can happen because of infection, for example, some hemorrhagic fevers, or it could be just the decrease in the platelet count, that is immune thrombocytopenic purpura. Then bleeding occurring because of various kind of blood cancers, aplastic anemia. We just had a discussion on that. So these are the most commonest causes of the bleeding occurring in a patient who comes to us in emergency room. Patient of an infection or septicemia, when he has suppression of the marrow and there is a bone marrow, there is a thrombocytopenia because of the immune destruction and the bone marrow suppression, which can actually mimic DIC, can also present with bleeding. Then we have the patients coming to us from congenital or acquired factor deficiency. Congenital, a pediatric patient will come with who's suffering from hemophilia, will have factor deficiency, or it could be an adult or an elderly patient who has been healthy all these years and suddenly develops purpura and starts bleeding. These are the patients who have acquired deficiency of the factors, and it is not uncommon, and mostly it is triggered by the infection. Or we can have the gastrointestinal bleeding, uncontrolled bleeding, bleeding in a female patient because of menorrhagia or postpartum bleeding, then urinary tract bleeding, and bleeding of the various miscellaneous causes. So all these patients come to us in the emergency room with bleeding, and then we need to do some screening test for the hemostasis. So can I request, do we have Dr. Pawan Goel here?
Yes, sir. Yes, sir. I'm there.
So Dr. Pawan, you have actually gone through these talks just now. So can you just enumerate one or two tests that we should do quickly in the emergency room to find out what could be the cause of the bleeding? I would request you to just give me one or two tests.
Yeah. So basically we should go for CBC, BTCT, and if available, PT and APDT. These are the very important lab tests, and one of the important causes of ER bleeding is hypertension, where we see uncontrolled epistaxis and some CNS bleeds also. So that has been omitted out, and we have to look for all these tests.
Dr. Pawan Goel, Pawan Goel is from Rewari. So yes, next slide, please. Yes, very right. That screening test has to be simple, quick, and easy. So most common are the CBC. Then we do the platelet count. Then the coagulation screening test, PT and APDT. This will give us fair amount of information, and we can diagnose almost all patients as far as the cause of bleeding is concerned. And we don't have to do any more tests in an emergency room. CBC, platelet count, PT and APDT. Most of the cases will be diagnosed by doing these tests. The other tests which I have enumerated here, platelet function tests or thromboelastography, these are actually not usually done in an emergency room, and they may be required to be done in the further management of these patients. If patient continues to have bleeding when all the other tests are normal, PTFD are normal, but he's having uncontrolled periodic bleeding and sometimes also develops some episodes of thrombosis, these could be the case of dysfibrosidemia, where we can have the fibrin levels done. In certain labs, these fibrin levels are available, and we should think in those patients where we are not able to find any cause of bleeding and all the parameters are coming as normal, but patient is having repeated bleeding. Then the DIC workup, which has been actually just enumerated upon by Dr. Avinash, that we have to just see the PT prolongation, whether they are correcting or not, and then we have to make a clinical diagnosis of DIC. Next slide, please. The bleeding actually in the presence of the inflammation, infection, is because of the various components, not just because of the prolongation of PT or low platelet count, but the main trigger is the endothelial injury, which initiates the inflammatory response, as it can be seen in traumatic bleeding, surgical bleeding, and infections. Next slide, please. This endothelial injury initiates the release of the cytokines, which actually is activated by the tissue injury, and these cytokines lead to the ischemic and ischemia, reperfusion injury, capillary leak, vasodilatory shock, MODS, and then the hemorrhagic shock. Alternatively, a patient may go towards the DIC because of the consumptive coagulopathy. Thus, a vicious cycle is formed, and this vicious cycle of inflammation-related thrombosis and bleeding has to be interrupted and stopped to improve the condition of this patient with continued bleeding. Remember that we are discussing here the continued bleeding. That is what we come across in emergency room more often in an undiagnosed patient. Next slide, please. So, what are the options to stop the bleeding? This was meant to be in a question, but I think it didn't get projected here. So the various options, Dr. Mukesh from Patna, are you there, Dr. Mukesh? Well, okay, he's not there. So Dr. Rajesh Kumar from Gurgaon. Is he there? All right. So we'll just enumerate these various options that we have are the blood components which were highlighted by Dr. Avinash in a great detail, use of FFP, cryo, and clotting factors. But when there is a massive bleeding, then we may actually have to use whole blood, for example, as we see in polytrauma or severe bleeding, and when the blood components are not available. So these are the various blood components that we are using in the various patients of bleeding. I have not mentioned the platelets. If patients of thrombocytopenia, then we use platelets also. Next slide, please. But there are some problems with these blood products. The blood products are not that benign. They can have problems. Next slide, please. Because, next slide, please. Because these blood products can initiate inflammatory response. Next slide, please. Can I have it? So this inflammatory response can further deteriorate the condition of the patient because blood component and the plasma which contains antibodies is actually in the initiator of the inflammatory response, which further deteriorates the condition of the patient. Can I have the next slide, please? Is there a problem? Yes. So it can actually, not only that it initiate the inflammatory response in the form of TRALI, which we know as transfusion-related acute lung injury, but there could be transmission of infections, transfusion reactions, and fluid overload. Next slide, please. So because of these problems, it is not always good to use the blood products. And as I mentioned, it is not a safe therapy, and we should actually look forward for treating the specific causes by just by stopping the bleeding, than by using just the blood components. Even though in most of these situations, conventionally we are using plasma, FFP, cryoprecipitated because of the availability that we have in our blood banks. Next slide, please. But over time, we know that yes, this is, I think, we already discussed this. Next slide, please. Next slide. So so when we don't want to use blood products, we have the alternative products available. Dr. Sumit, can you just tell us that what are the non-blood component products that we can use? Dr. Sumit? I think he's not there. Dr. Pawan, I can see him, he's there. So Dr. Pawan, can you just tell us various kind of blood product, the non-blood product drugs that you have been using ever? So what do you use? Have you ever used the tranexamic acid?
Yeah, we frequently use tranexamic acid. Aminocaproic acid also has been used quite often. And we also use ethamsilate and some snake venoms like butrocloth. They are used quite frequently in our practice. And in GI bleeds also we use desmopressin and like those products. Estrogens and other hormones are used usually in menorrhagia in females. And I have never used activated factor 7 in my practice. I don't have any experience of using recombinant active factor 7.
We'll come to that. Next slide, please. Yes, you have summarized very concisely the various products that we can use. Coming to this question of antifibrillatory agents, how do they help? The other panelists are not there. Dr. Srani, I'll come to that question later on. So can we have the next slide, please? So the antifibrillatory agents actually they augment the fibrin clot. Next slide. When there is a bleeding, the fibrin clot forms on the site of the bleeding. Next slide, please. At the site of bleeding, when the clot forms simultaneously, so that this bleeding does not progress. As you see here, the fibrin is formed, which actually stops the bleeding. So if there is a progressive fibrin formation, then the blood vessel will be blocked. So simultaneously, we have the activation of the fibrin, and which the activation of the plasminogen into the plasmin, which starts dissolving the fibrin, and as a result, the clot dissolves. But now in the coagulopathy, when the clot is weak, we want that whatever fibrin is getting formed, it should not dissolve. So we are retarding this process of fibrinolysis by using these antifibrinolytic agents so that whatever fibrin is formed does not get dissolved. So they actually stabilize the clot that is being formed in whatever suboptimal situation of the hemostasis. Next slide, please. So they are very effective in stopping the bleeding, but they are little under recognized. They are not used much, perhaps many times because of the ignorance, and many times because of the fact that we are so used to using blood components like plasma, cryoprecipitate, FFP, and even whole blood, which actually is not advisable. And now we know that by usage of the blood components more and more, we are causing a kind of harm to these patients, especially when they are having infections or inflammation, or they are having immune mediated diseases. So these can be used, actually it has been discussed in various indications. Dr. Asrani was already mentioning about the usage in the cardiac surgery and intracranial bleed. One of the very important indications are the menorrhagia and the postpartum hemorrhage, where by using it, by using the infusional therapy, the bleeding can be stopped to a great extent. As far as the urinary tract bleeding is concerned, if it is the upper urinary tract bleeding, the usage of antifibrinolytics is contraindicated. But in lower tract bleeding, they can be used. The main problem is that clot, which blocks the, which can block the canaliculi. There can be a problem because of the clot. So that's why it should not be used if the source of bleeding is known to be coming from the upper urinary tract. But if we have done the cystoscopy and we find the bleeding is not from the upper urinary tract, then these can be used. Even in liver transplantation, they have been used as infusional therapy, and they have been very effective, so much so that usage of blood components has significantly decreased by usage of the injectable antifibrinolytics, especially the tranexamic acid. They can be used in epistaxis, orally, IV, or even locally by crushing into the powder and using this as drops. Post-tonsillectomy and even in traumatic hyphema, they can be used very, very effectively. Next slide, please. Next slide. As I was mentioning, in menorrhagia, which is a common cause of iron deficient women, the usage can decrease the incidence of bleeding markedly, and patient can have a very comfortable life. Next slide, please. Dr. Asrani, in your experience, do you very frequently use the tranexamic acids in cases of bleeding, or still the blood components are being ordered more oftenly?
Not much, as you said it, Dr. Brigadier Ajay Sharma ji. You said it, not much, but we definitely discuss the issues. We withdraw, as I said it, if it is intracranial bleeding, if it is minimal, we withdraw the drugs and think condition would be controlled. And in otherwise cases, we have a practice in various hospitals to take the help of hematologists.
Yeah. So that's about the urinary tract bleeding, which we had just discussed. Next slide, please. Next slide. As I mentioned, liver transplantation, the blood loss is tremendous. Even though with the improved technique now, when the patient, the coagulopathy is managed without blood transfusions, the usage of the bleeding the incidence of bleeding has decreased, but still the infusion antifibrinolytic agents, especially the tranexamic acid, is used often in heavy dosages, and these patients do require less amount of blood components as compared to the fact when we are not using these agents. Next slide, please. Next slide. Similarly, in cardiac surgery, their usage can be of great help. So in all these usages, whether it is a regional bleeding, it is systemic bleeding, or it is an acute inflammatory bleeding, the antifibrinolytic agents should be more liberally. They can be used as oral drugs, they can be used as IV, infusional therapy, IV push or infusional therapy, It is just the confidence that the clinician has to have on these agents, and they should be started as soon as possible, because even if you order the blood components, it takes time, and we can start these agents immediately. Even in hemophilia, we can sometimes manage without giving the clotting factors, and the mild to moderate bleeding can be stopped by using these agents orally as well as an IV route. But the problem is that many times we use it in the under dosages. We don't give adequate dosages. We give them IV push while we need to give them IV infusional therapy because the half-life is short. The IV push therapy should be given more frequently than giving just once or twice in 24 hours. Next slide, please. Then I wanted to discuss the problems of these fibrinolytic agents because we don't have Dr. Sumit Jain. So I will just continue to this discussion that there is a problem with usage of tranexamic acid. Also, if we use in very high dose, in very high infusional dose, it can sometimes lead to thrombosis, especially the elderly age group. So we should be careful. We should be aware of this complication. So much so that aprotinine, which I'm sure Dr. Asrani must have used sometime or the other, which was a very popular agent and very effective agent, but it had to be withdrawn because of the high incidence of acute MI in these patients when it was being used in cardiology, in the cardiac surgery patients. The cardiac surgeons are very fond of using aprotinine, but it had to be stopped because of this complication. After a couple of years, that patients used to develop thrombosis, myocardial infarctions just after the surgery, but now we don't use it. So these are the side effects which we need to remember. I'm sure all of us know about this. Next slide, please.
Dr. Ajay, any limitation of using tranexamic acid?
Tranexamic acid. Yeah, the oral actually we don't need to be worried about because oral is not that problematic. But when we give IV infusional tranexamic acid for a long time, more than 15 milligram per kg body weight, then it can cause, in elderly age group, it can promote thrombosis. And especially if patient has got a history of thrombosis or we don't know about history of thrombosis, it can cause a problem. So we need to be aware about that. But certainly oral therapy is very, very safe. That can be used. And actually what we can do is we can start as IV therapy and switch over to oral therapy as early as possible. And that can be continued for a long time. What I wanted to discuss was this factor 7 usage, which Dr. Pawan was saying that he has not used, but I think if we now there are certain situations where it can be used, and very encouragingly and interestingly, most of the state governments now have procured this activated factor 7A, which is known as Novo 7, for usage in hemophilia patients. So a hemophilia patient who's bleeding because of the various reasons of inhibitors, antibody formation, septicemia, should not be denied effective therapy if Novo 7 it can be given. I'm sure the government of Haryana, government of Punjab, government of UP and Delhi state patients are getting Novo 7 as free drug from the government, provided the clinician justifies their usage. So coming to the activated factor 7A, this is what actually bypasses the coagulation system and forms the thrombin burst. And this is a very useful agent where in excessive bleeding, uncontrolled bleeding, where none of the other agents, even the blood components, don't help. Next slide, please. Yeah, we're just coming to the end of the presentation. So it has been now approved in hemophilias. Next slide, please. But it's more and more usage has been off-label use in all kinds of bleeding, in surgical bleeding, intracranial bleed, liver bleeding, PPH, and limb surgeries and life-threatening bleeding. In all indications, it can be used. Next slide, please. And in oral anticoagulation, excessive anticoagulation, certainly it has got a rule. I'm not going into dosage schedule. The one vial is 2 milligram. We can broadly we can say that we can give IV push 2 milligram the first dose and repeat it after 4 to 6 hours in case the bleeding is continuing. And when then we can use 3-4 doses in 24 hours on the day 1. And usually after 2 doses, that is at a gap of 15 to 20 minutes, we don't have to use the subsequent dosages. It is very effective. But we need to remember that again, that it can precipitate thrombosis and thrombosis related complication in elderly age group where the coronary heart disease could be a risk or it could be underlying disease. So coming to the to conclude, the bleeding remains a major cause of mortality in hospital patients as well as the trauma cases. The transfusion of blood products have the limitation in use. We can't use them all the times. Hemostatic agents, which actually are cheap, very cheap, and they are quite harmless. They are promising alternative to blood transfusions. They can be very effective if they are chosen at appropriate dosage and timings. The efficacy differs in different agents, but more efficacious agents can have severe toxicity. Hence, choosing an optimal agent remains the key to further success. With that, I conclude this session, and I think we are at the end of the hematology session, and I think it's getting a bit late. I am very thankful to the organizers, and I hand over the mic to Dr. Aditi with all the thanks.
Just I'll conclude
and I thank
before,
the panelists
before
and the
Dr. Aditi takes over. Thank you very much, Dr. Ajay Sharma, for wonderful panel discussion, and I'm thankful to organization, to Dr. Rangarao, to Dr. Aditi, and handing over to Dr. Aditi and Dr. Vineet Nakra for further quiz, and I'm signing off. Thank you very much. Thank you, Aditi.
Thank you, sir. Thank you, all the faculty. It has been running late, and I'm really thankful to you that you've been patient and still attending, interacting, discussing. All the interactions were really fruitful and knowledgeable, because the prime aim was early diagnosis and how we interact on a day-to-day basis with the primary care physicians, that is the ENT surgeons, the hematologists, the physicians, and I hope the deliberations, the discussions were fruitful to the PG students as well. So thank you, Dr. Israni, thank you, Dr. Rajesh Sharma, and thank you all the panelists. Thank you so much for the discussion. Now moving on towards the last part of today's session, which is the quiz. Before we start the quiz, I just want to invite all of you for tomorrow's session, which would start at 5:30 tomorrow, because there is a special event of the inaugural session, which will have two keynote sessions by Dr. Rath, who is the Chief of NCI and AIMS, and Dr. C.S. Pramesh, who is Director Tata Memorial Hospital, from 7 to 8. So the scientific sessions will begin at 5:30 till 7 to 8 we'll have the inaugural, and again from 8 o'clock till 9:30 we'll have the scientific sessions again. So please do join us for the scientific sessions and the inaugural as well. And now we'll be starting the quiz, which is for the PG residents. So over to you, Dr. Vineet. Dr. Vineet is a senior
Excuse me,
resident
ma'am.
Hospital, Noida.
Yeah.
Yeah.
Hello, ma'am. PCC quiz tab is now available in Hall D. Please announce that also.
Okay, so PCC quiz tab is available in Hall D now. So all the PG students who wish to participate in the quiz can please click on that link, click on that tab, and then they can start attempting the quiz, because it will be timed for 15 minutes. There will be 20 questions. Dr. Vineet will be reading out those questions, and at the end of 15 minutes, the timer will be off. So your responses after those 15 minutes cannot be recorded. There is a form that you have to attempt, a few basic details, including your name, email ID, phone number, your year of post-graduation, and then you can proceed to the quiz. So technical team, do we start the quiz now?
And ma'am, please announce that everyone has to refresh their screen once to get the quiz tab available in the Hall D.
Okay, so all the delegates have to refresh their tab once to get the quiz tab. They just have to refresh their screen. They'll get the quiz tab, and then they can move on to the quiz tab and start attempting the quiz. So
we can start now, ma'am.
No,
we can start now, ma'am.
We'll wait for a few seconds so that everyone understands what we've said, and then we'll start. So in maybe another 30-40 seconds, we can start. Over to you, Dr. Vineet.
Okay, after 1 minute, we will start the timer.
Fine.
For 15 minutes.
So, but then the time that the students or delegates are taking to fill up those details, that would be counted in these 15 minutes?
Yes, ma'am. Yes, ma'am. That is included.
So maybe we can make it 21 minutes then, not 20.
Okay.
16.
We will make it for 20 minutes.
No, 16 minutes instead of 15 minutes. We give 1 minute extra.
Okay,
Yes,
ma'am.
I
Okay.
think we should give some time for filling out the forms.
Yeah, so 1 minute I think is fine. It's just 2-3 details.
Yes, ma'am.
16 minutes. Okay, fine.
Should we start now, or should we wait for some time?
The technical team is going to tell us 1 minute.
Okay, ma'am.
Then that 1 minute is over. Shall we start? Aram, we can start.
Just wait for a minute, ma'am.
Okay.
You have started the timer. Wait.
No, ma'am. I think he's setting up the timer.
Yeah, we are setting up the timer, ma'am. Yes, we may start now. We may
Aram,
start
can you
now, please.
Please share the PPT. I'll open my stopwatch for timing the questions.
Please share the PPT.
Aram, if you can share the PPT. I cannot see the PPT, Aram. But the timer has started.
Shall we stop the timer?
Yes, you should, because the screen is not on display right now.
Yeah.
So the quiz is not started yet.
You can stop and restart the timer, but the PPT needs to be
Yeah,
shared.
no problem. We will restart the timer. No problem.
Yeah. Yeah, now I can see the screen. So good evening, everyone. After a tiring yet very informative day, today at the Paras Cancer Conclave, we have a quiz now, which consists of 20 questions. I hope you all have filled the forms. So we'll start with the first question. I hope you have it on your screens as well. Which of the following nerves is not associated with otalgia related to a mass in the oral tongue, base of tongue, larynx, or hypopharynx? Your options are auricular temporal branch of cranial nerve 5, Jacobson's nerve of cranial nerve 9, posterior auricular nerve, or Arnold's nerve. Please mark your responses. We can stay on the timer a bit. Second question. 68-year-old lady presents with a 1.5 centimeter P16 positive squamous cell carcinoma of the right tonsil. resected via transoral robotic surgery. An ipsilateral right selective neck dissection of level 2 to level 4 demonstrated a 2.5 centimeter lymph node with the extracapsular extension of less than 1 millimeters. All other nodes resected did not show evidence of any malignancy. According to the 8th AGCC cancer staging edition, which was started in 2017, this patient's pathological stage is, your options are PT1N1, PT2N2, PT2N1, PT1N2, or PT1N3. Next question. Next question. What was the 2-year larynx preservation rate in the concurrent chemo-RT arm of RTOG 9111? Your options are 95%, 88%, 70%, or 65%. Next question. Next question, Aram. Aram, question number 4, please.
Can we have the next question, please?
Can we have the next question, Aram?
Sudhir, please change the slide.
Next slide.
अरे उससे नहीं हो रहा, तुम चला दो यार, उससे भी नहीं चल रही लग रहा है.
Okay, so question number 4. I hope the audience can see it. What is the approximate rate of PEG tube dependence following chemoradiation for head and neck cancer? Your options are 5%, 15%, Next question. So this is a picture-based question. You can see on your screen a woman. She presented to her doctor with dysphagia and altered taste sensation. On physical examination, she was found to have atrophy of the left tongue and a tumor in the left fossa of Rosenmüller. Which syndrome accounts for these symptoms? Your options are Gifford syndrome, B. Villaret syndrome, Fraze syndrome, or Horner syndrome. Next question. Question 6. Which of the following statements regarding nicotine replacement therapy is true, which was popularized by the former president of the United States, Mr. Barack Obama? Your options are NRT increases the odds of quitting smoking compared to placebo. NRT is associated with increased risk of carcinogenesis in the general populations. Option C, both A and B, or option D, none of the above. Which of the following statements regarding NRT is true? Next question.
Vineet, I think you'll have to be a little
Lee-Fraumeni
quick.
syndrome is characterized by which clinical features? Option A, lobular breast cancer, gastric cancer. Option B, breast cancer, soft tissue sarcoma, central nervous system tumors. adrenocortical cancer, leukemia, prostate cancer. Option C, breast cancer, hematoma, thyroid cancer, oral mucosa cancer, endometrial cancer, brain tumors. Or option D, male breast cancer, pancreatic cancer, gallbladder cancer, pharyngeal cancer, gastric cancer, melanoma, or prostate cancer. Next question, please. So currently, these two people are Nobel laureates recently, Mr. James Allison and Tasuko Honjo. What is the proposed mechanism for using immunotherapy to destroy cancer cells currently? Options are develop antibodies to target growth factors on cancer cells, increase levels of immune lymphocytes, C, develop antibodies to directly destroy the cancer cells, or option D, increase levels of antigen presenting cells. Next question. Which of the following is false regarding giant cell tumors? Your options are: the majority are not malignant, there is more than 90% local control with surgery alone, local control rates with radiation alone are poor, or these occur most commonly at the epiphysis. Which of the following statements is false regarding GCTs? Next question. Question 10. A 75-year-old man with a history of T2N1 anal canal squamous cell cancer treated with concurrent chemoradiation 1 year ago presents for follow-up. Which of the following should be performed as a routine follow-up? Option A, PET-CT. Option B, biopsy of the treatment site. Option C, digital rectal exam. Or option D, MRI of the pelvis. The patient has come after concurrent RT, CT 1 year later. Next question. Historically, what percentage of newly diagnosed lung cancer is small cell lung cancer? Option A, 20%. Option B, 30%. Option C, 40%. Or option D, 50%. Next question. Question 12. Which of the following individuals would meet the criteria to have surveillance for hepatocellular cancer? Option A is a 28-year-old African woman who is a hepatitis B carrier. Option B, a 47-year-old Indian woman who is a hepatitis B carrier and has a brother with hepatocellular carcinoma. Option C, a 62-year-old Hispanic male with alcoholic cirrhosis. Or option D, a 42-year-old Chinese man who is a hepatitis B carrier. Or there is an option E, all of the above. Next question. Question 13. Which of the following neoplasias is an intraepithelial marker for invasive cancer? Option A, cervical ectropion. Option B, a junctional nevus. Option C, a seborrheic keratosis. Or option D, leukoplakia. Next question, please. Which of the following cancer is increasing in incidence in the world? Option A is lung cancer among women. Option B, colorectal cancer. Option C, breast cancer. Or option D, melanoma. You have a hint in the screen. This famous Jamaican singer was affected with the cancer and he died of this disease. That is the cancer which is actually increasing in incidence in the world. Next question, please. Question 15. Of the genes listed below, select the gene that is involved in both cell cycle regulation as well as DNA repair. Your options are TP53, B, NBS1, C, PTTG1, or option D, CHK2. Which of the following genes is involved in both cell cycle regulation as well as DNA repair? Next question. Which of the following statements is correct? A, hereditary non-polyposis colon cancer syndrome is associated with a 25% lifetime risk of developing colorectal cancer. Approximately 10% of all cases of colorectal cancer are associated with HNPCC. Option C, microsatellite instability is associated with resistance to 5-fluorouracil chemotherapy. Or option D, none of the above. Next question. What is the most common site of osteosarcoma? Option A, tibia. Option B, femur. Option C, fibula. And option D, humerus. I think this is the very easy question. Next question, please. Choose the correct answer that orders the following radiation fields from the largest to the smallest field. So you have to arrange the fields from the largest to the smallest size of the fields. Option A, involved site, involved node, mantle field, or involved field. Option B, mantle field, involved site, involved node. Option C, mantle field, involved site, involved field, involved node. Or option D, involved field, mantle field, involved node, or involved site. Among the four options, you have to select from the largest to the smallest field. Next question. So which cancer affected the celebrities which are shown in the picture? The first picture is of Ian McKellen, who is popularly the Magneto in X-Men. Second celebrity is Colin Powell, the ex-foreign minister of the United States. And the third is Mr. Warren Buffett. He's one of the richest people in the world. Your options are skin cancer, prostate cancer, soft tissue sarcoma, or laryngeal cancer. All three of them were affected with one of these diseases. Next question. So the last question of the quiz today is, which of the following is the most common molecular abnormality seen in patients with prostate cancer? Your options are KRAS mutation, BRAF mutation, P53 mutation, or chromosomal translocations involving TMP RSS2. I think by exclusion, this is a very easy question to answer by exclusion. I think we should stop sharing the screen after this. Aram?
Then
After
we
this
can stop
question?
the slideshow, yeah.
Yes, we should stop the slideshow now. Don't go to the next slide. Thank you so much, Dr. Aditi ma'am, for letting me conduct this quiz today. I'll be
Thank
happy
you.
to conduct the quiz tomorrow as well.
Sure.
And
Thank
I
you,
think
Vineet.
we've wrapped up a marathon day out of the 3 days. Thank you so much, ma'am. All the best to all the participants. I hope the technical team has recorded the answers. I don't know how they have recorded it. They told me that there will be some tab on the websites.
So thank you, Vineet, for conducting that quiz. And the responses have been recorded and submitted, and our technical team shall be analyzing them. So the results of the quiz shall be announced on the last day, because there will be a quiz tomorrow as well. So results of day 1 and day 2 both will be announced on day 3, and we have attractive prizes. We are Amazon gift vouchers. We have 3 first, second, third prize, as well as a few consolation prizes also. So if you've missed on the quiz today, I would really urge you to attend it tomorrow and encourage.
Now I hope. Now I wish I was attending the quiz and not.
Okay. Next time. Fine.
Right.
So here we come to the end of the session, and I would like to thank all of you for being so patient. We've been running late for our schedule, and I would like to invite all of you for tomorrow's session, which will again start at 5:30 p.m. and the link will be the same for the delegates, and hope to see you tomorrow, 5:30 p.m. Thank you, everyone.